Now I'm going to begin by briefly reviewing anatomy of the secondary pulmonary lobule. Some of the abnormalities we identify because of abnormalities of the pulmonary lobule. And this is a radiograph of a lung slice of two adjacent pulmonary lobules. And what we can see are the lobules being marginated by connective tissue interlobular septa. These contain pulmonary vein and lymphatic branches. In the center of the pulmonary lobule is a branching centrolobular artery, and it is large enough to see on high-resolution CT, and adjacent to it is the centrolobular bronchiole, which is too thin-walled to be seen in normal subjects. Pulmonary lobules range from 1 to 2.5 centimeters in diameter and characteristically have this polygonal shape. Now, this is the high-resolution CT finding of interlobular septal thickening. What we identify is a reticular pattern, and we can identify this reticular pattern as due to interlobular septal thickening because the lines we see outline what we can recognize as pulmonary lobules because of their characteristic size and shape. And one of the ways we recognize these as lobules is the centrolobular artery, which is usually visible as a dot or branching structure in the center of what you think is a pulmonary lobule. And then within the interlobular septa themselves, we often can make out septal veins, and these may be dot-like or occasionally branching. Interlobular septal thickening, in this case, it is due to interstitial pulmonary edema, certainly a common cause of that abnormality. Well, what do you do if you see interlobular septal thickening on high-res CT? Well, first of all, you ignore it unless it is the predominant abnormality, because a little bit of septal thickening will be very common in almost any diffuse lung disease you see, and unless it predominates, it's of no value in differential diagnosis. Interstitial pulmonary edema is a common cause. Lymphangenic spread of neoplasm, a common cause. There are some other infiltrative diseases that result in interlobular septal thickening, but they're relatively rare, and I'm not really going to go into those in detail. An example would be amyloidosis, something of that sort. And patients who have diffuse lung fibrosis can show interlobular septal thickening, but it is characteristically irregular in contour, and usually we have other findings of fibrosis that we rely on to make the diagnosis. Well, this is simply a chest film in a patient who has pulmonary edema, and you can see curly B lines. Curly B lines are the plain radiographic appearance or plain radiographic correlate of interlobular septal thickening as we see it on high-res CT. Now here's another patient. A high-res CT shows smooth thickening of interlobular septa. You can see a number of thickened septa within the right lung. The left lung looks relatively normal, so this is at least asymmetrical and probably unilateral in distribution. That would be quite unusual for interstitial pulmonary edema. Here, a lower scan in the same patient. Again, we see thickening of interlobular septa within the right lung and not on the left. Also, a right pleural effusion is evident posteriorly. This is the other common cause of interlobular septal thickening we see, lymphangenic spread of carcinoma. This is a patient who has lung cancer, and the septa are thickened because of lymphatic infiltration. This is a lung slice in a different patient who has lymphangenic spread of carcinoma, but you can see thickening of the interlobular septa by tumor cells, and this results in this characteristic appearance of asymmetrical or unilateral septal thickening. The next finding I'm going to talk about, another reticular abnormality, is honeycombing, and I think you can recognize this as honeycombing. It's a very nice example. And this is a patient who has usual interstitial pneumonia, UIP, due to the lung disease idiopathic pulmonary fibrosis, IPF, and we'll talk further about both of those. Now, I'm going to digress for a moment and talk about the idiopathic interstitial pneumonias. They're an important group of lung diseases that you need to know about. These represent reactions to lung injury. The interstitial pneumonias are pathological responses of lung to injury. They are not diseases per se, but they are ways in which the lung can react when it is injured. They occur in several patterns with variable inflammation and fibrosis. They have a variable response to treatment, and they may be idiopathic or may be associated with collagen disease, may be associated with drug treatment. inhalation. There are a number of other causes as well, but keep in mind that these idiopathic interstitial pneumonias may be idiopathic or they may not. They may be associated with some other disease. Now, these are the interstitial pneumonias or idiopathic interstitial pneumonias as currently accepted. These are UIP, usual interstitial pneumonia, NSIP, nonspecific interstitial pneumonia, OP or organizing pneumonia, DIP, desquamative interstitial pneumonia, quite similar to another entity termed respiratory bronchiolitis, interstitial lung disease, and then LIP, lymphoid interstitial pneumonia, and AIP, acute interstitial pneumonia. Now, the first four of these are common, and we see these first four on a regular basis in our clinical practice. The last two are not so common. LIP, often associated with collagen disease, and I will show you an example of that in my last slide. And AIP, acute interstitial pneumonia, is basically idiopathic ARDS. If someone is in the ICU with ARDS and they don't know why, it may be AIP. And generally speaking, AIP is something that's evaluated with plain films in the ICU on a daily basis and not with high-resolution CT. Okay, now the American Thoracic Society, ATS, and European Respiratory Society got together and classified these interstitial pneumonias in 2001 and agreed on some terminology because we tended to use different terms in the United States than were used in England and Europe, and this is what they agreed upon. First of all, they made a distinction between the histologic pattern of the interstitial pneumonia. Remember, an interstitial pneumonia is not a disease, it's a histology. And then the idiopathic clinical syndrome associated with that interstitial pneumonia. And the histologic pattern of UIP, when it is idiopathic, is called IPF, or idiopathic pulmonary fibrosis. The histologic pattern nonspecific interstitial pneumonia, when it is idiopathic, is called idiopathic NSIP. The histologic pattern organizing pneumonia, when idiopathic, is called COP, or cryptogenic organizing pneumonia, although sometimes in the US we refer to it as idiopathic BOOP. The histologic pattern desquamative, or DIP, desquamative interstitial pneumonia, when idiopathic, is just called DIP. Now, what this classification did not emphasize, but I'm going to emphasize now, is that each of these histologic patterns may be associated with a given disease or various types of diseases. UIP may be a result of collagen diseases, drugs. Asbestosis is basically a UIP pattern. NSIP, very commonly associated with collagen diseases, may be a drug reaction, other causes as well. Organizing pneumonia has lots of causes. It may be post-infectious, collagen diseases, drug reactions, inhalation of fumes, may be seen with hypersensitivity pneumonitis. And in the vast majority of patients, DIP is associated with cigarette smoking. So these may be idiopathic or they may be associated with disease. Okay, we'll start by talking about usual interstitial pneumonia. This is quite common in clinical practice. The histology is heterogeneous lung fibrosis. What we see on high-res CT is reticulation, a finding called traction bronchiectasis, and honeycombing is seen in about 70% of cases. And this combination of findings is typical of this pattern. Ground glass opacity is very uncommon as an isolated finding. That means in areas that don't show findings of fibrosis. The abnormalities have a basal, posterior, and lower lobe predominance. That's very important in diagnosis. Idiopathic UIP is IPF. It has a very poor prognosis. Also, the differential diagnosis, as I have mentioned, collagen diseases, asbestosis, drug fibrosis, end-stage hypersensitivity pneumonitis may be associated with UIP on histology. Now, this is a lung slice, a sagittal lung slice in a patient who has UIP associated with idiopathic pulmonary fibrosis. And what you can see on this path specimen is honeycombing with a posterior lower lobe predominance. This is a lung slice in a patient who has honeycombing, and just to emphasize what this means, honeycombing indicates the presence of cystic lucencies. These are air-containing, these are empty holes, so they should look absolutely black on high-res CT. 3 to 10 millimeters in diameter most of the time, but may be larger or smaller. They must be seen, and I emphasize that, must be seen in a subpleural location, or you can't be sure they are honeycombing. Unless you see these subpleural, they may be something else. Early on, you will only see a few isolated cysts. Later on, cysts occur in several layers, and cysts share walls when numerous. And these have a tendency to occur in clusters, and they're not simply black holes, they have a recognizable wall surrounding them, which is fibrotic. This is the plain film appearance of a patient who has UIP-IPF. What we tend to see is a decrease in lung volumes. The lungs look small, and at the lung bases, you see an increase in reticular opacities, although usually you can't figure out exactly what it is you're looking at. This is the lateral view, and again, you can see reticulation that predominates at the bases and in the posterior costophrenic angle. Another example of honeycombing on high-res CT, again, we're seeing black holes. These look to be a little less than a centimeter in diameter. They're occurring in clusters and layers. They have thick, recognizable walls. This is a very good, definite example of honeycombing in a patient with UIP-IPF. Another example with a posterior lower lobe predominance of reticulation, traction bronchiectasis, and a little bit of honeycombing, UIP-IPF. Differential diagnosis of honeycombing is basically the differential diagnosis of UIP. The histologic pattern usually associated with honeycombing that we see on high-res is UIP. Differential is IPF, idiopathic pulmonary fibrosis, collagen diseases, particularly rheumatoid and scleroderma, drug-related fibrosis, methotrexate or something like that, chronic hypersensitivity pneumonitis, asbestosis, uncommon in clinical practice these days. End-stage sarcoid can be associated with honeycombing as well in a few patients. And I should say that fibrotic, nonspecific interstitial pneumonia, NSIP, the different interstitial pneumonia, may also be associated with a little bit of honeycombing, but it typically has a different appearance. Now, I mentioned that reticulation and traction bronchiectasis is a finding we see in UIP. It's a finding that indicates the presence of fibrosis. This is what I mean by traction bronchiectasis. These bronchi are very irregularly dilated. They appear corkscrewed because of fibrous tissue that's pulling on their walls and making them dilate. This is not airways disease. It is fibrosis causing the bronchi to dilate, and they have this very, very characteristic irregular appearance and will be associated with reticulation, as we see here. And this is a lung slice in a patient who has UIP-IPF. And we can see a very nice example of traction bronchiectasis in the posterior lung, and also this patient has honeycombing, which you can see in the subpleural region. So this finding of reticulation and traction bronchiectasis also associated with this disease and with lung fibrosis in general. Now let's talk about IPF. It's a very common disease, and it's the most common cause of UIP. If you have this disease, if you have IPF, then your histology must be UIP. Patients are usually older than 50 at diagnosis. They have progressive dyspnea. Mean survival only about 3 years, 5-year survival 25 to 40%. Having IPF is basically like having lung cancer. It's a disease that is very difficult to treat and not very responsive. Now recently, the American Thoracic Society, European Respiratory Society, Japanese Respiratory Society, and Latin American Thoracic Association got together and they decided on criteria for making a diagnosis of IPF. And this is very important because this is a common disease. And these are the criteria that they came up with, and this was just published this last year. Number 1, exclusion of known causes of ILD. That means exposures, connective tissue diseases, drug toxicity, things of that sort. So basically, this first criteria means that the disease is idiopathic. Number 2, a UIP pattern seen on high-resolution CT. That is all you need to make a diagnosis of IPF with this current classification. It's idiopathic, and high-res CT looks like UIP. The diagnosis is IPF. Lung biopsy usually not performed in that situation. If a lung biopsy is performed, and as I said, it's not usually done, then various combinations of high-res CT and histologic patterns are used to reach a final diagnosis, and I'm not going to get into that. What I want to emphasize is idiopathic disease, UIP on high-res CT, the diagnosis is IPF. Now, this is what they mean by a UIP pattern on Hiro Ct. UIP pattern, a subpleural basal predominance of abnormalities. Okay, we've seen that. Reticular abnormalities, we've seen that. Honeycombing, and then no inconsistent features, and I'll tell you what those are in a second. If those 4 criteria are met, then it's definite IPF, or definite UIP pattern. Possible UIP pattern is exactly the same thing, but without honeycombing. Okay, so honeycombing necessary to make a definite diagnosis of a UIP pattern. Now here's an example of a UIP pattern on Hiro Ct. There's reticulation in the upper lobes and in the mid-lung zones, but the disease predominates at the lung bases in the posterior subpleural lung. There's reticulation. We can see little irregular reticular opacities here and there, and then we see honeycombing. There are no atypical features, so this is a UIP pattern. If this person has no known associated diseases, this is IPF, period. Now here is a patient with a basal posterior subpleural predominance of reticulation, but no honeycombing. This would be diagnosed as possible UIP using those same criteria. And usually a person like this would have a lung biopsy for final diagnosis. This was early UIP IPF. Now, what are the inconsistent findings? What are the findings that tend to rule someone out? Well, these are findings that tend to go with some other disease. An upper mid-lung or peri-bronchovascular predominance. That's not what you see with UIP. Extensive ground glass opacity. That's something like hypersensitivity pneumonitis. Perfuse nodules, sarcoid or something. Discrete cysts, well, that'll be histiocytosis or LAM or something of that sort. Mosaic perfusion air trapping, that's some sort of airways disease or hypersensitivity pneumonitis. And then consolidation, which is a Uip finding or organizing pneumonia finding. So these inconsistent features are things that are typically seen with some other disease. Well, here are a couple examples. This is a patient who has great honeycombing. It's subpleural predominant. There's a lot in the lung bases. So this is a UIP pattern, but this patient has rheumatoid arthritis. So this cannot be IPF because he has an associated disease, and we would call this rheumatoid lung disease. Here is a patient who shows a great example of honeycombing in the lung bases, so that looks like a UIP pattern, but also recognize that he has calcified pleural plaques and he is asbestos exposed. So because he has this exposure, this cannot be IPF, but it is a UIP pattern, and we would call it asbestosis. Okay, nonspecific interstitial pneumonia. This is less common than UIP, and this is a specific entity despite its name. You may have heard at AFIP that NSIP does not exist. That is wrong. NSIP is a real disease. It is a specific pattern despite its name. The histology is homogeneous inflammation or fibrosis, unlike UIP, which is heterogeneous. It occurs in 2 forms, cellular and fibrotic. It's common, very common in patients with collagen vascular disease. Also occurs with drug reactions or may be idiopathic, and has a good response to treatment with 5-year survival, 80 to 90%. What we tend to see on Hiro Ct is ground glass opacity and reticular opacities in some sort of combination, but ground glass is often a predominant feature. If you see ground glass opacity alone in patients with this disease, it is the cellular form. If you see ground glass opacity plus reticulation, it's either cellular or fibrotic, you can't be sure. If you see traction bronchiectasis in association with reticulation, since that's a finding that tends to go with fibrosis, fibrotic NSIP is likely. And if you see a little bit of honeycombing, then it's fibrotic NSIP. And I should mention that in distinction or in contradistinction to UIP, honeycombing is quite uncommon in fibrotic NSIP, and when present is quite minimal in extent. So you don't quite see the same appearance you do in UIP. It also has a lower lobe posterior and peripheral predominance, but it has a specific finding that is extraordinarily helpful in making this diagnosis, and that is sparing of the immediate subpleural lung, which is present in 20 to 60% of cases. Now here an example, a 43-year-old woman with dyspnea for 3 months. Prone scans show ground glass opacity with a peripheral lower lobe predominance, but notice that the immediate subpleural lung is less abnormal than lung a couple centimeters away. That is subpleural sparing. That is a finding that is very, very highly predictive for NSIP. And this is concentric lower lobe ground glass, subpleural sparing, nonspecific interstitial pneumonia. Another patient looks just the same. A little bit of reticulation and ground glass opacity in the peripheral lung and posterior lung, but notice subpleural sparing. Classic NSIP. Now here is a patient who shows reticulation and traction bronchiectasis. So the reticular opacities here, these little holes, are dilated bronchi seen in cross-section. That's traction bronchiectasis. I'm not calling this honeycombing because it's not subpleural. Maybe that's one honeycomb cyst right there, but honeycombing is inconspicuous in this disease. Notice that there is relative subpleural sparing. The lung immediately adjacent to the pleura is less abnormal. This is a classic example of fibrotic NSIP. So we're seeing reticulation, traction bronchiectasis, not so much ground glass opacity, subpleural sparing. And here another example, reticulation and traction bronchiectasis with subpleural sparing, fibrotic NSIP. Now these are survival curves on top for NSIP, survival curve over 9 years, and this is the survival curve for comparison for UIP-IPF, and you can see that IPF has a much worse prognosis than NSIP of all sorts. And if you distinguish cellular NSIP from fibrotic NSIP, cellular NSIP much better than UIP, fibrotic somewhere in the middle. Now here are two classic examples of the two interstitial pneumonias I've talked about so far, UIP and NSIP. These are the appearances you should look for in trying to distinguish these two diseases. On your left, honeycombing at the lung bases, classic UIP pattern, likely IPF. On your right, we're seeing ground glass opacity with subpleural sparing, classic NSIP. Okay, the third interstitial pneumonia, respiratory bronchiolitis and desquamative interstitial pneumonia, almost all cases related to smoking. Respiratory bronchiolitis is a very common histologic abnormality in smokers. If you have a patient who's a smoker who's getting a lung biopsy, you can bet that they will have RB on biopsy because all smokers do basically. If that histologic abnormality is associated with symptoms, it is called respiratory bronchiolitis, interstitial lung disease. If the disease is much more extensive, it's usually called DIP. It's a similar histology, but much more extensive in distribution. DIP, much less common than the other interstitial pneumonias I've talked about so far. I don't see very many cases. Treated with steroids or smoking cessation, and prognosis is good. And you can almost count on the fact that someone who has a diagnosis of DIP will continue smoking and take steroids. Respiratory bronchiolitis and DIP, histology is intraalveolar macrophages with very little fibrosis. Ground glass opacity is what we see. Patchy or centrolobular nodules tend to predominate in patients who have the entity of respiratory bronchiolitis, interstitial lung disease. And ground glass opacity is more diffuse in DIP, maybe patchy or subpleural distribution. It's variable. This is a 56-year-old smoker, and you can see here there's sort of patchy ground glass opacity. Maybe if you use your imagination, you can see that some of these ground glass opacities have a centrolobular predominance. This is respiratory bronchiolitis. Here's a patient with much more extensive ground glass opacity. And these little cysts tend to occur in people that have DIP. I'm not sure exactly what they are, probably areas of air trapping or little nematoceles or something like that. But this is a typical appearance of DIP in a heavy smoker. So if you know your patient is a smoker, these entities are something to consider, but they're not very common, and they don't generally pop up in my differential unless I know the patient is a heavy smoker. Okay, back to high-res CT findings. We'll talk first about consolidation. Consolidation means increased lung opacity with obscuration of underlying vessels, and that is distinguished from ground glass opacity, where the lung is increased in attenuation, but you can still see vessels within the abnormal lung regions. So if it's entirely white, it's consolidation. If you can still see anatomy in the abnormal region, it's ground glass. Differential for consolidation depends on the duration of the patient's symptoms. It's a very simple way to approach it, but it's the way I do it. If the symptoms with consolidation are acute, then you think of pneumonia, pulmonary edema, pulmonary hemorrhage, or diffuse alveolar damage, which is the histology of ARDS. If you see consolidation in patients with chronic symptoms, and by that I mean 6 weeks or more, then I think of organizing pneumonia, chronic eosinophilic pneumonia, and what we used to call diffuse BAC, bronchial-alveolar carcinoma, but the name is in the process to being changed to invasive mucinous adenocarcinoma. That is a change that's occurring. BAC is not a term we're going to be using in about a year. I'm not even using it anymore now. Mucinous adeno. So here a patient with lupus, acute dyspnea. The finding is consolidation. Symptoms are acute. Differential diagnosis is pneumonia, edema, hemorrhage, something of that sort. This was pulmonary hemorrhage. 73-year-old with pneumonia and fever for 6 weeks on treatment. So these are chronic symptoms. The finding here is consolidation. Differential diagnosis is going to be different, and the things I think of first are going to be organizing pneumonia, chronic eosinophilic pneumonia, which is basically the same as organizing pneumonia, and then diffuse bronchial alveolar carcinoma, invasive mucinous adenocarcinoma of the lung. And this was organizing pneumonia with patchy consolidation, a very typical finding. Okay, we'll talk about organizing pneumonia for a second. The histologic pattern is granulation tissue polyps and bronchioles associated with patchy organizing pneumonia. Organizing pneumonia is associated with a syndrome often known in the US as Uip. The ATS-ERS prefers organizing pneumonia or COP as terms to use. I generally say organizing pneumonia unless I'm among friends, and then I love to say Uip, as you know. Quite common. Idiopathic infection, drugs, collagen diseases, fume inhalation, or various causes. Several months of cough, dyspnea, and low-grade fever are typical. These patients often appear as if they have a pneumonia that hasn't been adequately treated. It responds well to steroids, has a good prognosis, 5-year survival, basically 100%. High-res CT findings, patchy airspace consolidation or ground glass is seen in most. Large nodules or masses, peripheral and peribronchial distribution is typical. These areas of consolidation are in the subpleural lung or around the central airways. The opacity is often quite irregular in shape. Findings of fibrosis uncommon and mild. And there's a finding that is particularly suggestive of this entity, and it may be called the atoll sign, but more typically or commonly referred to in the literature as the reversed halo sign, common with organizing pneumonia. This is a patient with amiodarone treatment who has progressive dyspnea. What we're seeing are areas of consolidation which are peripheral and peribronchial, very irregular in shape. This is a great example of organizing pneumonia as a drug reaction. And this is the atoll sign. What we see here are areas of consolidation that are rim-like, and then ground glass opacity in the center, or here crescents with ground glass opacity. Here a very funny shaped one with ground glass opacity in the middle. This is the halo sign, which I'm sure you've heard about, a dense central nodule surrounded by a halo of ground glass opacity, commonly seen with angioinvasive aspergillosis. And this appearance is sort of the exact opposite of the halo sign, which is why it has been referred to as the reversed halo sign. But also, I think it very strikingly resembles an atoll, and this term actually appeared in the literature first, although it happened to be in Italian. But this is an atoll, and I have this down for my own residents because only about half know what an atoll is. A ring-shaped coral reef enclosing a lagoon and surrounded by the open sea. And the atoll itself often has a few breaks in it so the tide can go in and out, and these often have breaks in them. And this looks whiter than it does on the outside, which is what an atoll sign looks like as well. But as I said, my residents don't generally know this. Apparently they don't spend quite as much time in Hawaii as does the faculty. Organizing pneumonia. If you see this atoll sign, very, very highly predictive for organizing pneumonia, although it can be seen with a few odd infections as well. And these are pictures from the literature of the reversed halo sign in COP, or cryptogenic organizing pneumonia, and in this study that was seen in about 20% of cases, but you can see these little atolls quite nicely. Now, chronic eosinophilic pneumonia may be idiopathic or associated with a known antigen. Peripheral eosinophilia usually present. Symptoms are about the same as for organizing pneumonia. Asthma is a common association. It is basically identical to organizing pneumonia in CT appearance and symptomatology. We see peripheral ground glass opacity or consolidation. This tends to have an upper lobe predominance and rapidly responds to steroids. And there's a good deal of overlap histologically and clinically in everything between organizing pneumonia and eosinophilic pneumonia. Some pathologists think they are the same thing, basically, one with eosinophilia and one with less eosinophilia. But keep in mind that this is a different thing that can look exactly the same. This is a patient with 2 months of cough and dyspnea. We see these areas of consolidation, peripheral and peribronchial. Some of these look like they're showing an atoll sign, but this person has a peripheral eosinophilia, and this is chronic eosinophilic pneumonia. Looking exactly the same as organized pneumonia, and again, these are probably the same thing. And here a patient with months of progressive cough and shortness of breath, a lot of consolidation here on both sides. This is invasive mucinous adenocarcinoma of the lung, again formerly known as BAC, with consolidation. And in patients who have this tumor, what's going on is the tumor grows along alveolar walls with a pattern termed lipidic growth. But the tumor cells produce mucin and fluid, and that fills the alveoli and causes the consolidation that we see on CT. It's not the tumor that causes the consolidation, but the mucin. Okay, this is ground glass opacity. Now what we see again is increased lung opacity, but vessels remain visible in the abnormal regions. Air bronchograms may or may not be seen. This happens to be Goodpasture syndrome with pulmonary hemorrhage. Now this is an appearance of normal alveoli, and ground glass opacity may result from alveolar wall thickening, partial alveolar filling, decreased alveolar air. Each of those can result in ground glass opacity as we see it on CT. And here, courtesy of Photoshop, I have done that. Here I have thickened the alveolar walls. That will result in increased tissue within that voxel. That will appear as ground glass. Here I have filled some of the alveoli with a pink proteinaceous fluid. That will result in increased attenuation in ground glass. And here I have shrunk down that piece of lung to a smaller volume. That will also result in increased attenuation. Now, I approach the differential diagnosis of ground glass opacity exactly the same way I approach consolidation, based on the chronicity of symptoms. If the patient has ground glass on CT with acute symptoms, differential is pulmonary edema, pulmonary hemorrhage, atypical pneumonias, diffuse alveolar damage. Basically the same differential, but you consider different sorts of infections, atypical instead of bacterial. Patient with acute dyspnea, sort of a parahilar bat wing appearance to ground glass opacity. This is diffuse alveolar damage due to cocaine or cracked lung. Chronic symptoms with ground glass, the differential diagnosis is a lot longer and more complicated. It includes interstitial pneumonias such as NSIP and DIP, hypersensitivity pneumonitis, a very common disease, organizing pneumonia, chronic eosinophilic pneumonia, mucinous adenocarcinoma again, lipoid pneumonia, rare due to aspiration of lipids, and alveolar proteinosis. Here a patient with 3 months of progressive dyspnea, so chronic symptomatology with these multiple areas of ground glass opacity, hypersensitivity pneumonitis, again a very common disease. Now hypersensitivity pneumonitis is caused by inhalation of various organic antigens. The responsible antigen, however, can only be identified in about half of cases, even if you try really hard. It occurs in acute, subacute, and chronic stages. Repeated exposures cause fever, chills, dry cough, and dyspnea. Symptoms are progressive over months or years, and chest radiographs just totally unhelpful in making this diagnosis. Now, typically patients with hypersensitivity pneumonitis present in the subacute stage, and the appearance that we see on high-res goes along with the histology that is present. It's a very nice correlation. These patients have an alveolitis with alveolar wall infiltration, and that appears as diffuse or patchy ground glass opacity. They have peri-bronchiolar granulomas that are very ill-defined, and those result in the appearance of ill-defined centrolobular nodules of ground glass. And they also have a cellular bronchiolitis that causes mosaic perfusion, and that's patchy lucencies with air trapping. These may be diffuse or predominant in the mid-lung zones and involves the entire cross-section of lung and does not have a subpleural predominance, as do some of the other interstitial pneumonias. So here we see a patient with dyspnea for months. We see these patchy areas of ground glass opacity. We see lucencies that probably represent mosaic perfusion due to air trapping. The disease involves the entire cross-section of lung, geographic ground glass opacity, hypersensitivity pneumonitis. 66-year-old bird fancier with progressive dyspnea, a very, very similar appearance. We see a rather diffuse ground glass opacity appearance, but then these lucencies, these areas of mosaic perfusion or air trapping, this one looking just like a pulmonary lobule, hypersensitivity pneumonitis, very typical appearance. This is an expiratory view in the same patient, and you can see air trapping within these pulmonary lobules because of the bronchiolitis that is associated with this disease. Now, in patients who have chronic hypersensitivity pneumonitis, typically we see reticulation and traction bronchiectasis, maybe a little honeycombing. There is no subpleural predominance, and upper lobes are often most abnormal, and that's quite distinct from the appearance you see in UIP or the other interstitial pneumonias, again involving the entire cross-section of lung. Now, this is an unusual appearance of ground glass opacity, but I'll show it to you because it's quite typical. Patient with 6 months of progressive dyspnea, so ground glass with chronic symptoms. It's from that second list I showed you. This person also shows the appearance of crazy paving, where interlobular septal thickening is associated with the ground glass. And I should say as a disclaimer that you may see crazy paving in any cause of ground glass opacity, acute or chronic. But the appearance of crazy paving has become associated with alveolar proteinosis because it is a very typical appearance in alveolar proteinosis, but it is a non-specific Hiro Ct finding. If I see it, I might suggest this diagnosis. Otherwise, I would almost never suggest alveolar proteinosis as a diagnosis in any case I see. Just so rare. This is the histology of alveolar proteinosis, and it goes along with the CT. What we see is filling of those alveoli with a proteinaceous material causing the ground glass, and then that same material accumulates within interlobular septa and causes the crazy paving appearance. Okay, diffuse lung nodules. Now, when we see nodules as the predominant abnormality on CT, we can characterize the nodules into one of three specific patterns, and that helps with differential diagnosis. And the three patterns are perilymphatic, random, and centrolobular. This is the appearance of a perilymphatic distribution of nodules, and with this pattern, nodules occur in relation to lymphatics. They predominate in three places: in the subpleural lung adjacent to fissures and peripherally, adjacent to central bronchi and vessels, or peri-bronchovascular, and lastly within interlobular septa. So this is the typical distribution and location of nodules with this pattern. Because it occurs, or the nodules occur only in these specific regions, the overall appearance tends to be patchy. Differential diagnosis, sarcoid, almost all, 95% of cases at least are sarcoid. Lymphangenic spread of tumor, silicosis and co-workers pneumoconiosis uncommon, amyloid rare, lymphoid interstitial pneumonia rare. Again, 95% of patients who have a perilymphatic pattern have sarcoid. This is a nice example. Subpleural nodules peripherally, subpleural nodules adjacent to the fissure. This is a photograph of the surface of a lung in a patient with sarcoid, and you can see these subpleural nodules quite easily. Here, peri-bronchovascular nodules, another typical finding with a perilymphatic pattern and with sarcoid. A lung slice in a patient with sarcoid, the nodules predominate around the central bronchi and vessels. Mediastinal nodes are seen in up to 90% of patients with sarcoid. Hilar nodes also very typical. The nodes are symmetrical and are described as having a 1-2-3 pattern on chest film. I'll show you that. Lung disease is seen on chest film in about half of cases, many more on high-res CT. What we typically see are perilymphatic nodules, most subpleural and peri-bronchovascular, with an upper lobe predominance. We see upper lobe masses, big conglomerates of sarcoid nodules associated with little nodules around their outside. Those are satellite nodules, and that has been called the galaxy sign. And later, upper lobe fibrosis, fibrotic masses, and traction bronchiectasis result, along with cysts and emphysema in some patients. So this is the characteristic 1-2-3 pattern of sarcoid, right mediastinal, bilateral hilar. Sometimes you see nodes in the AP window that is sometimes called a 1-2-3-4 pattern, but typical adenopathy in sarcoid. In a patient with sarcoid here, we can see a lot of lung disease as well, many nodules in the upper lobes in addition to hilar prominence. A patient with sarcoid here, extensive subpleural and peri-bronchovascular nodules and masses, and these are conglomerates of sarcoid granulomas. This appearance with large masses and little nodules around the outside or satellites has been called the galaxy sign and is quite suggestive of this diagnosis. In people that have end-stage sarcoid, basically where you have the active nodules, it all turns into fibrous tissue, and you often get these fibrotic masses in the upper lobes with traction bronchiectasis. And here on plain film, typical appearance of sarcoid with fibrosis, bilateral, symmetrical, upper lobe fibrosis, some cyst and emphysema, but these irregular masses of fibrous tissue in relation to the hila. And sarcoid has a propensity to be associated with aspergillomas, a very common association. And here a patient with fibrotic sarcoid and these upper lobe masses of fibrous tissue with traction bronchiectasis. And here a cyst or an area of emphysema on the left with an aspergilloma inside it. Now the appearance of sarcoid can be mimicked by silicosis or co-workers pneumoconiosis. And here a patient with simple silicosis showing subpleural nodules and peri-bronchovascular nodules. This is a patient with complicated silicosis where fibrosis has occurred in relation to these nodules, and you get these upper lobe masses that look very much the same as fibrotic or end-stage sarcoid. Complicated silicosis, and here the CT that could be associated with that appearance. Again, these masses of fibrous tissue associated with traction bronchiectasis in the upper lobes in patients with complicated or progressive silicosis. And here's some calcification occurring in relation to those. So sarcoid and silicosis can appear quite similar in the active stages or in the fibrotic stages. And another finding you may see in either sarcoid or silicosis, but is more typically or classically seen with silicosis, is eggshell calcification, where you see this little rim calcification of mediastinal or hilar lymph nodes. The second pattern of nodules is termed random. Random distribution relative to lung structures. They occur anywhere and everywhere. You see subpleural nodules in this pattern, but there's no predominance in the subpleural regions, an overall uniform distribution. Differential diagnosis is hematogenous disease, miliary tuberculosis, miliary fungal infections, hematogenous METs. And sarcoid, when the nodules are extremely numerous, can mimic this appearance of a random pattern. Now here a good example, diffuse nodules, uniform lung involvement, subpleural nodules present, miliary TB. This a lung slice in a patient with miliary TB. It's just this very diffuse distribution with nodules also seen at the pleural surfaces. And on plain radiograph, these numerous small discrete nodules typical of miliary TB. Another example, miliary cocci and AIDS, diffuse lung distribution, subpleural nodules present, but diffuse and uniform lung involvement. And here a patient with an adenocarcinoma that is metastatic to lung. There are nodules at the pleural surfaces, but diffuse and uniform lung involvement. So random pattern is hematogenous disease. Now the third pattern of lung nodules we can see is centrolobular. And with this pattern, the nodules are occurring in relation to the centrolobular bronchiole or artery. The most peripheral nodules you see adjacent to a fissure or adjacent to the chest wall are about 5 millimeters away from the pleural surface. That's where the centers of the lobules are. Now, because lobules are about the same size, the centrolobular pattern appears diffuse and uniform, but keep in mind that with this pattern, you do not see nodules at the pleural surface as you do with a random pattern. And the overall appearance in different diseases, diffuse or patchy. Now, a very quick algorithm that lets you distinguish these three patterns: multiple nodules, no pleural nodules present, it's a centrolobular distribution. Differential diagnosis, small airway or small vessel diseases. Subpleural nodules present with diffuse and uniform lung involvement, it's a random pattern and hematogenous disease. Subpleural nodules with a patchy or non-uniform distribution, perilymphatic, usually sarcoid. Here's a patient with diffuse nodules. What is the pattern? Well, the lung is involved in a diffuse and uniform manner. Pleural surface is spared, so this is a centrolobular pattern. The nodules are of ground glass opacity. That's very typical appearance for hypersensitivity pneumonitis. Centrolobular nodules of ground glass opacity. And the histology associated with that, here an interlobular septum, a centrolobular bronchiole, and then a nodule or nodules of ill-defined granulomas surrounding the bronchiole. Differential diagnosis of this pattern, well, it's a little bit longer than the others. Any form of bronchiolitis, infectious or inflammatory, endobronchial spread of tuberculosis or mycobacteria, bronchopneumonia, any cause, hypersensitivity pneumonitis, respiratory bronchiolitis, interstitial lung disease, endobronchial spread of tumor, again, mucinous adenocarcinoma instead of BAC. Pneumoconioses can do it, silicosis in an early stage. And then vascular disease is much less likely, but pulmonary edema, pulmonary hemorrhage, or some vasculitis. Here a patient with bronchopneumonia, shortness of breath and fever. We see centrolobular nodules here of soft tissue attenuation. So infection is certainly on the differential diagnosis high on the list when you see centrolobular nodules. 27-year-old with cough, shortness of breath, and fever, a few cavities in the lower lobe, centrolobular nodules. This is endobronchial spread of TB. Here, invasive mucinous adenocarcinoma or diffuse BAC with centrolobular nodules due to endobronchial spread. So that's the differential diagnosis. Okay, a very important finding, and it's something I think Brett will probably talk about in the next presentation, is tree and bud. Tree and bud refers to an appearance we see when there is dilatation and impaction of centrolobular airways. Resembles a budding tree. If it did not resemble a budding tree, it would be a very stupid name, but it does. These opacities tend to be centered 5 to 10 millimeters from the pleural surface because they're basically centrolobular. The branching opacities we see with this pattern is more conspicuous than you see with normal branching vessels in the lung periphery, and often tree and bud is associated with centrolobular nodules as well. Now, this is what tree and bud looks like. In a drawing, this is what tree and bud looks like. In a patient, we see this branching structure in the lung periphery that represents a dilated, impacted centrolobular airway. Sometimes you see a little cluster of nodules, or you see the buds better than the tree branches. Basically is the same thing. Here, another nice example of tree and bud in between the two. Now, basically, if you see tree and bud, as we see in this case, it's going to be an infection. We reviewed a number of these a few years back, and every case we looked at with tree and bud had some sort of infection, very uncommon in non-infectious airways diseases. So if you see this appearance, and it's a very characteristic appearance, you can bet that the patient has some sort of airway infection. A patient with AIDS-related airways disease due to chronic infection. Beautiful examples of tree and bud in the right lower lobe. If I see that, I know I'm looking at an infection. This is a lung slice in a patient who has this sort of bronchopneumonia. You can see these airways impacted with material in the peripheral lung causing this tree and bud appearance. So differential diagnosis, endobronchial spread of TB or MAC, infection, 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 infection. Aspiration occasionally does this, not very common. I've seen 1 or 2 good cases. Allergic bronchopulmonary aspergillosis or asthma with mucoid impaction, not very commonly associated with this. and very occasionally it's reported with BAC. I have not seen a good example myself. Generally speaking, if I see tree and bud, my diagnosis is infection, and that's all I'm going to consider unless I have information to the contrary. Nice example here of multiple trees in bud in the lower lobes on a prone scan, beautiful branching opacities. I'm going to think this is infection, and it's Pseudomonas bronchopneumonia. Okay, emphysema. We're almost done. Emphysema occurs in 3 forms: centrolobular, pan-lobular, and paraseptal. And they have different appearances. Centrolobular emphysema is nicely shown in this patient, and what you typically see are these black holes that are spotty and involve the upper lobes in a sort of spotty fashion. That's a good way to describe it. They generally do not have recognizable walls, although you may see very thin walls in some patients. This is the appearance of centrolobular emphysema on a plain film. We see upper lobes, again this is an upper lobe predominant abnormality, that are much too hyperlucent, may be increased in volume as we see here, and have vessels that are very small or spindly. The second type of emphysema is pan-lobular emphysema. This results in almost total obliteration of pulmonary lobules themselves, and we tend to recognize this as lungs that are too big, too black, and have vessels that are too small. We do not tend to see the same sort of focal abnormalities, focal holes, like you do in centrolobular emphysema, so this may be difficult to diagnose in early cases. Everything just looks too big, too black, vessels too small. On plain film, what you tend to see is emphysema that is diffuse or has a basal predominance. This often associated with a basal predominance on plain film. You can see the lower lobes are quite lucent. And this is the type of emphysema that's associated with alpha-1 antitrypsin deficiency. The third type of emphysema is paraseptal, and this occurs in the lung periphery, and you have these focal areas of emphysema that basically represent pulmonary lobules. They have walls that you can see, and those usually correspond to interlobular septa. This type of emphysema may be idiopathic or may be associated with smoking and centrolobular emphysema, as we see here, but if you see this subpleural emphysema, you call it paraseptal. The last finding I'm going to discuss is lung cysts. Now, lung cyst is usually defined as a localized air-filled lesion. I mean, you have bronchogenic cysts and things like that that have fluid in them, and they have that specific name, but in general, the term lung cyst refers to something that is air-filled. It has a thin but visible wall. It has a wall that's recognizable, usually allows it to be distinguished from emphysema, and is well circumscribed. Now, the differential diagnosis, well, honeycombing is a cystic abnormality, so when you say somebody has honeycombing, you are saying that you see multiple lung cysts in a subpleural location with a thick wall occurring in clusters or layers. Emphysema, if you have a bulla in a patient with emphysema, it has a thick and recognizable wall. That is a lung cyst. So the term cyst can be used with these diseases. If you have a patient with pneumonia who develops pneumatoceles like PCP, that is, the pneumatoceles are lung cysts. It's just a very general term. Hypersensitivity pneumonitis in some patients may be associated with cysts due to air trapping. But there are several lung diseases that are characterized by lung cysts as the primary or only abnormality. And these are quite rare. These are histiocytosis, lymphangiomyomatosis, LAM, and the lung disease of tuberous sclerosis. Those are quite rare. And Sjogren's syndrome or other collagen diseases associated with lymphoid interstitial pneumonia or LIP, also relatively rare. But these are cystic lung diseases, and I'm distinguishing these from these more common causes of lung cysts that we can usually diagnose as what they are. Now, this, first of all, is a patient who has these patchy areas of ground glass opacity, and then multiple lung cysts in the upper lobes, and obviously a pneumothorax, because one of the cysts has popped. And let's say this person has acute symptomatology, which he probably does because he has a pneumo. But if we see ground glass opacity in association with acute symptoms, we think of pulmonary edema, pulmonary hemorrhage, atypical pneumonia. And this patient has AIDS, and this is pneumocystis with nematoceles. So this is a disease we're going to be diagnosing not based on the cysts, but based on the clinical presentation and other findings that we see. This is histiocytosis, again, a primarily cystic lung disease. Thick-walled cysts are seen in this patient, and they're quite typical. And you can see that the cysts are fewer in number and smaller in size at the lung bases, and that's quite typical of histiocytosis. And the cysts also have very irregular shapes, which is characteristic of this disease. So cysts irregular in shape in histiocytosis, thick or thin-walled in different stages of the disease, and you can see that these are thin-walled at the base. There's an upper lobe predominance in size and number. In early cases, you may also see nodules in association with the cysts, and this is a smoking-related disease. Only people that have, in adults who develop histiocytosis that looks like this, the disease is associated with cigarette smoking. Here's another patient, Langerhans histiocytosis. Notice on a plain film we're seeing some upper lobe lucency. The pulmonary hyla are large because this person has pulmonary hypertension associated with this. These are the CT scans. You can see cysts being irregular in shape and larger in the upper lobes than at the lung bases, although the bases are also involved. Langerhans cell histiocytosis. And this is this patient's lung, removed at lung transplantation, and you can see that there are numerous cysts in the upper lobes. Cysts predominate in size and number compared to the lower lobe. This is a 21-year-old smoker with cough. Notice that in this patient we're seeing nodules and we're seeing thick-walled cysts that are rather small in size, and we're seeing a few things you might call cavitary nodules. This is Langerhans cell histiocytosis in an early stage. This is when you're seeing nodules and before the cysts, or just as the cysts are starting to develop. So there's the progression in Langerhans histiocytosis: nodules, cavitary nodules, thin-walled cysts. 35-year-old woman, lungs are large and lucent. This is a high-res CT seen through the upper lobes in this young woman. This is lymphangiomyomatosis, or LAM, with cysts. Lower lobes, cysts are just as big and just as numerous. So characteristic of cysts in LAM, they're round in shape, not irregular like histiocytosis. Usually thin-walled, as we see here. The wall's pretty thin. Diffuse in distribution, both upper and lower lobes. These occur only in women of childbearing age. I have seen one man with LAM. It was associated with tuberous sclerosis. Otherwise, these are all women that are childbearing age, sometimes older. This is not going to go away if you go into menopause. You occasionally present later on, but usually childbearing age. 1% of patients with tuberous sclerosis show this sort of appearance, rarely in men. And here, the cysts at baseline, 2 years later, they're bigger and more numerous, and this is her lung at lung transplantation, diffuse lung involvement. And the last case, a 72-year-old woman with Sjogren's syndrome and lymphoid interstitial pneumonia, excuse me, LIP. We see thin-walled cysts, usually in people with this disease, LIP, lymphoid interstitial pneumonia with cysts. The cysts are countable, usually limited to a couple dozen. If I made a resident count these, it would be possible. Not possible with histiocytosis, not possible with LAM, but you can count the cysts typically in a patient with LIP, in association with collagen disease. Cysts round in shape, thin-walled, diffuse, limited in number. A few dozen is quite typical. In the first presentation this morning, I discussed UIP, nonspecific interstitial pneumonia, and organizing pneumonia. They're the three most common interstitial pneumonias I see in clinical practice. The other two diseases that I see very commonly and commonly get confused with interstitial pneumonias because of presenting symptoms are sarcoid and hypersensitivity pneumonitis, and I will be discussing both of those in this talk. Sarcoid results in the presence of microscopic non-caseating granulomas that occur in clusters, and it's the clusters we can see on CT, not the individual granulomas. Symmetrical lymph node enlargement or calcification also may be seen. 60 to 70% of patients have characteristic plain film findings that can lead you to the diagnosis. 10% or so have normal chest radiographs, and high-res CT is abnormal in most patients with sarcoid who have normal chest radiographs. Usually in that situation, nodules are seen on high-res CT. Lymph node enlargement occasionally seen, but many patients with normal chest films and abnormal HRCTs in sarcoid don't have adenopathy. The high-res CT findings we see include small nodules, which are usually well marginated, sharply defined, and appear solid. They're not of ground glass opacity. They appear solid on high-res CT. There's an upper lobe predominance in most patients who have sarcoid, and often the abnormalities involve the lung in a patchy fashion. The nodules show a typical perilymphatic distribution, and I will describe for you in some detail what a perilymphatic distribution looks like. And typical lymph node enlargement or calcification is suggestive of the diagnosis in association with the other abnormalities, but is not necessary for diagnosis if you see typical nodular lung disease. Now, this is a demonstration of the distribution of perilymphatic nodules typical of sarcoid. And nodules with this distribution are called perilymphatic because the nodules are occurring in relation to lymphatics wherever there are lymphatics in the lung. And lymphatics occur in specific locations. They are subpleural. So you see subpleural nodules in the periphery and subpleural nodules adjacent to fissures in patients with a perilymphatic pattern. You see nodules in relation to central bronchi and vessels. Lymphatics travel in association with the bronchi and vessels. So Peri-Bronchovascular nodules are part of that pattern. And nodules in relation to interlobular septa, which contain lymphatics. Now, because the nodules are occurring specifically in relation to these areas or structures, the overall appearance of nodules that you see when you look at the CT is patchy or non-uniform. Now, this is a very typical CT in a patient who has sarcoid, sort of bad sarcoid, but a nice example. We see nodules in the periphery at the pleural surface and nodules at the pleural surface adjacent to the fissure. Subpleural nodules typical of sarcoid and this pattern. And this is a photograph of the surface of a lung in a patient who has sarcoid, and you can look down through the pleural surface and see these clusters of nodules or clusters of granulomas as these subpleural nodules. Now, also notice there are nodules in association with the central bronchi and vessels, Peri-Bronchovascular nodules, and this the cut surface of lung in a patient with sarcoid showing clusters of these nodules or granulomas in relation to a central bronchus. So this also a very typical location for nodules in sarcoid. Subpleural and Peri-Bronchovascular is a typical perilymphatic distribution, and it's very typical of sarcoid. The differential diagnosis. Well, sarcoid accounts for at least 90% of patients I see with a perilymphatic distribution of nodules. It's a very, very common cause of this. Other causes, silicosis and co-workers pneumoconiosis, lymphangenic spread of carcinoma, lymphoid interstitial pneumonia, one of the interstitial pneumonias I didn't talk about this morning, and amyloid. So there's a sort of a list of uncommon diseases here with exception of, now here's some more examples, perilymphatic nodules in sarcoid, Peri-Bronchovascular and subpleural nodules. Those arrows are pointing at nodules in relation to central bronchi and vessels. And here, nodules at the pleural surface adjacent to the fissure. So patchy nodules, Peri-Bronchovascular and subpleural, typical perilymphatic, typical of sarcoid. Sarcoid with Peri-Bronchovascular and subpleural nodules with an upper lobe predominance. Again, upper lobe predominance is quite typical of sarcoidosis. Centrolobular Peri-Bronchovascular nodules may be seen, nodules in a centrolobular location. There are a few examples. I will describe a centrolobular distribution in a few minutes, but centrolobular nodules may occur in sarcoid because bronchi and vessels occur in the centers of lobules, and sarcoid likes to be Peri-Bronchovascular, so the nodules may be seen in relation to small vessels and bronchi in the lung periphery. This, the histology that would be associated with that, a small centrolobular bronchiole, and adjacent to that, a number of these small nodules, small sarcoid granulomas that result in a larger nodule we can see. Now, interlobular septal thickening or interlobular septal nodules are not as common as a finding of sarcoid, but may be seen. These are scans in the lung base in a patient who has sarcoid, and you can see some interlobular septa that show nodular thickening. It's part of a perilymphatic pattern, but not particularly common in this disease. Now, some additional findings may be seen in sarcoid. Large nodules or masses in up to a quarter of patients. These are usually bilateral. They are upper lobe predominant because that's where sarcoid is predominant, and parahilar in location. Air bronchograms may be seen in relation to these nodules or masses, and you can often see small nodules or clusters of nodules adjacent to the periphery of these larger masses. Those are called satellite nodules, and that whole constellation of findings with the big mass and the surrounding satellites has been termed the galaxy sign of sarcoidosis. So that's something that can be helpful when you see these large masses. Now, these masses generally represent a confluence of smaller interstitial granulomas. There are just so many peri-bronchovascular granulomas that they form these larger masses. And then if fibrosis develops, these masses may end up representing fibrous tissue, but early on, they represent confluence of granulomas. This has been termed alveolar sarcoid, but this is a misnomer because all these granulomas that result in these masses and the air bronchograms are actually interstitial in location. Now, ground glass opacity may also be seen in sarcoid. Again, this represents a confluence of small granulomas that simply result in a hazy increase in lung attenuation. And satellite nodules may be seen in relation to these areas of ground glass as well, helping you to make the correct diagnosis. Now, here's a patient with sarcoid and subpleural and peri-bronchovascular nodules. And some of the nodules, when confluent, form these larger parahilar central masses. And you can see in relation to the periphery of these some satellite nodules, and you could call that the galaxy sign if you wished. Sarcoid, again, with confluent parahilar nodules, some air bronchograms, and then adjacent to the periphery of these masses, you can see satellite nodules, and taken together, again, that is called the galaxy sign. A patient with sarcoid and clustered small nodules resulting in the appearance of ground glass opacity. If you sort of sit back and look at this, it looks like the patient has patchy areas of ground glass, but if you look inside these opacities, you can see the numerous small nodules representing clusters of sarcoid granulomas. And then adjacent to the periphery of these areas of ground glass, you can see individual discrete nodules or satellites that help you decide this is a granulomatous disease and not something like a atypical pneumonia or pulmonary hemorrhage or something of that sort. Now, sarcoid may also be associated with airway abnormalities. These may result in obstruction of large airways. You can have masses of sarcoid granulomas that will obstruct a main or lobar bronchus. You can have small endobronchial granulomas, and small airway obstruction may result from these bronchiolar or airway abnormalities, resulting in mosaic perfusion and or air trapping on expiratory scans. So sarcoid can result in both large airway and small airway abnormalities. Now, here are two examples. On your left is a lung slice in a patient with sarcoid. We're looking at a large bronchus here, and you can see all these little knobby things within the bronchial lumen. Those are clusters of sarcoid granulomas, and these may result in airway obstruction or lobar collapse, something of that sort. Here we're looking at a cross-section of a small airway in the lung periphery, a very small bronchiole, and you can see the wall is abnormally thickened by numerous granulomas. This may cause small airway obstruction, and then secondary to that, mosaic perfusion or air trapping. Now, here a nice example. This is a 45-year-old patient who presented with dyspnea. CT shows a mass within the left hilum obstructing the left upper lobe bronchus. At a lung window setting, you can see that there is significant left upper lobe atelectasis. Notice, however, there are one or two other nodules that are visible in addition to this collapsed lobe, but you would have to consider lung cancer as a likely diagnosis. This is a scan that was as part of this same CT that extended down through the upper abdomen, and you can see a number of low attenuation lesions within the spleen. This has a differential diagnosis, of course, but one of the causes is sarcoid. This is a typical appearance for sarcoid involving the spleen. So in the differential diagnosis of this case, we suggested, well, it could be lung cancer with splenic mets, or it could be lymphoma, or it could be sarcoid. Well, he had a bronchoscopy, and sarcoid was diagnosed. There were endobronchial granulomas that were causing the left upper lobe bronchial obstruction. He was treated for sarcoid, and a year later came back with a CT scan that's more typical of cases of sarcoid we see, with some patchy nodules that are peri-bronchovascular and subpleural, sort of typical appearance of sarcoid on high-res CT. Here, a patient with sarcoid and small airway obstruction with air trapping, an inspiratory scan in the upper left-hand corner. You can see a few scattered nodules here and there. On the expiratory image in the lower right, you can see marked air trapping involving a number of different lung regions, lobules, and multilobular areas of air trapping. This sarcoid with small airway involvement. But seeing air trapping like this is not uncommon in patients with sarcoid if you do expiratory imaging. Now, later on in patients with sarcoid, as the disease becomes chronic and as fibrosis develops, nodules decrease but often remain visible. Reticulation develops with lung distortion occurring in the regions that showed granulomas or nodules during the active stage of disease. So we tend to see peri-bronchovascular fibrosis because that is where the granulomas were when the sarcoid was active, usually upper lobe, which is quite unlike idiopathic pulmonary fibrosis and usually allows the two diseases to be distinguished rather easily. But the peri-bronchovascular fibrosis can result in those same sort of perihilar upper lobe masses. Conglomerate masses of fibrous tissue may result. Traction bronchiectasis is often seen in relation to these masses. And subpleural honeycombing may be seen in a few patients, and on occasion, an individual scan in a patient with sarcoid will look like IPF or UIP, but the distribution is different, upper lobe versus lower lobe. Emphysema and cysts often develop in late-stage disease, and these may lead to the formation of mycetoma. Now, here are a few examples. Sarcoidosis with fibrosis, peri-bronchovascular reticulation involving the upper lobe. So we are seeing fibrosis here in the peri-bronchovascular regions, in the upper lobes and mid-lung zones, because this is where the active disease was when the patient had granulomas. And you can see reticulation and distortion of lung parenchyma and a little bit of traction bronchiectasis within the abnormal mass of fibrous tissue. Another example, sarcoid with peri-bronchovascular conglomerate fibrosis, traction bronchiectasis within those masses of fibrous tissue, and lung distortion. Another example looks much the same, peri-bronchovascular conglomerate fibrosis, and here on an expiratory image in the same patient, you can see patchy areas of air trapping. Again, air trapping quite common in patients with sarcoid, and the air trapping persists even in patients with late-stage disease. You can develop, or patients with end-stage sarcoid can develop cystic lesions in the upper lobes. Sometimes these represent dilated bronchi, and sometimes they're simply cysts, but this appearance not uncommon in end-stage sarcoid, and because of these, mycetoma is reasonably common in patients who have end-stage sarcoid with lung fibrosis. Okay, the second topic, or second half of this presentation, has to do with hypersensitivity pneumonitis. Now, hypersensitivity pneumonitis is a very common disease. It's caused by inhalation of organic antigens. However, I should emphasize that the responsible antigen is identified in only about half of patients. Even if you have a patient with biopsy-proven hypersensitivity pneumonitis, you send a visiting nurse to the home to search through the home for pets and air ducts and mushrooms and whatever. You can't find the responsible antigen in at least half of cases. Even though you know there's something going on, even though you know the diagnosis, you can't always figure out what the cause is. Hypersensitivity pneumonitis occurs in 3 stages, acute, subacute, and chronic. Usually patients are initially diagnosed, or at least come to initial attention during the subacute phase. They have progressive symptoms over months or years. Repeated exposures to whatever the antigen is produces fever, chills, dry cough, and dyspnea. Now, in the subacute stage, the histology
well, first of all, in the subacute stage, what we typically see are ill-defined centrolobular nodules. 50 to 60% of patients show that. These are usually of ground glass opacity. And the histology sort of predicts the high-res CT findings. These ill-defined centrolobular nodules represent clusters of poorly marginated granulomas that are occurring adjacent to airways as a result of a reaction to the antigen they're inhaling. Patchy ground glass opacity, up to 90% of patients. This is associated with lung infiltration as the process becomes more generalized. Patchy mosaic perfusion or lucent regions due to air trapping may be seen. If you do expiratory scans, air trapping is very common in this disease. This occurs because of the bronchiolitis that is associated with the centrolobular or peri-bronchiolar granulomas. And if you see a combination of patchy ground glass opacity and lucent regions of mosaic perfusion, which is quite common in this disease, that has been very eloquently termed the head cheese sign by me. And it's a finding that is very helpful in suggesting the diagnosis, something that's pretty easy to recognize and can lead you quite quickly to the correct diagnosis. I'll show you all about that. Now, this disease tends to be diffuse or predominates in the mid-lung zones. Unlike IPF, it involves the entire cross-section of lung. If you're looking at the CT scan, it does not predominate in the periphery, does not predominate in the central lung, and involves the entire cross-section of the lung you're looking at. No subpleural predominance. Now, centrolobular nodules, typical of this condition in many patients. What do they look like? What is their appearance on CT? Well, these nodules are occurring in relation to the centrolobular bronchiole in this disease, but may also occur in relation to the centrolobular artery, as Paige showed you in patients who had pulmonary veno-occlusive disease. The most peripheral nodules you see when you are dealing with a centrolobular pattern are about 5 millimeters from the pleural surface, because that's where the centers of the most peripheral lobules in the lung are. So nodules with this pattern do not involve the pleural surfaces, as they do with a perilymphatic pattern. They stay away from the pleural surface. And because lobules are all about the same size, these nodules appear evenly spaced if you look at the overall CT scan. Now, here's a nice example: subacute hypersensitivity pneumonitis with centrolobular nodules of ground glass opacity. Notice that the most peripheral nodules are a few millimeters from the pleural surface. The nodules are not arising at the pleural surface. There's a little black line adjacent to the pleural surface where the nodules are not visible. And here at a lower level, the same sort of appearance: centrolobular nodules sparing the pleural surfaces. Notice adjacent to the fissure, you also see that little black line because the nodules are not involving the pleural surfaces. Very typical of a centrolobular pattern and typical of subacute hypersensitivity pneumonitis in many patients. Now, this is histology that would go along with that appearance on high-res CT. What we are seeing here is a centrolobular bronchiole. If I can find my arrow, there it is, the centrolobular bronchiole, and then poorly marginated granulomas in relation to the centrolobular bronchiole that give these centrolobular nodules. Now, the differential diagnosis of centrolobular nodules, well, usually it's going to represent some sort of a bronchiolitis, infectious or inflammatory. It may represent an infection with endobronchial spread. Hypersensitivity pneumonitis, one of the common causes of centrolobular nodules. Endobronchial spread of neoplasm, used to be called bronchiolo-alveolar carcinoma, now is mucinous adenocarcinoma. Pneumoconiosis, silicosis, for example, can give centrolobular nodules because the dust is first deposited there. And then vascular causes, pulmonary edema, pulmonary hemorrhage. But most of the causes of centrolobular nodules are small airway diseases, and one of the common ones is hypersensitivity pneumonitis. Another example of subacute hypersensitivity pneumonitis with poorly defined, ill-defined centrolobular nodules of ground glass opacity, and then also focal lucencies representing mosaic perfusion due to air trapping. Here another level in the same patient, the poorly marginated, hazy centrolobular nodules of ground glass opacity, very typical of subacute hypersensitivity pneumonitis and something that should be high on your list if you see this appearance. Now, here's subacute hypersensitivity pneumonitis with patchy areas of ground glass opacity. That's one of the other common appearances of this. And mosaic perfusion, I'm just going to define because I'll be talking about it for the next few minutes. Mosaic perfusion represents inhomogeneous lung attenuation, usually geographic, due to differences in lung perfusion. About half the density of lung is blood. If you reduce perfusion to a specific lung region, its attenuation will decrease as well. With vessels appearing relatively large in the dense lung regions, reflecting the difference in perfusion. Airways disease is most frequent as the cause. The low attenuation regions are often lobular in patients with airways disease as a cause of mosaic perfusion, and air trapping is visible if you use expiratory scans. Vascular obstruction, less common as a cause of mosaic perfusion. Page showed you a nice example of that in his pulmonary hypertension talk. Now, mosaic perfusion or air trapping may be an isolated abnormality in several different diseases: bronchiolitis obliterans, asthma, and hypersensitivity pneumonitis. Now, this is an example of mosaic perfusion here in inspiratory scan. Notice that there are patchy areas of lucency. Here is a single pulmonary lobule that appears lucent, and that is because there is less perfusion of that lobule because of a airway abnormality. And here on the expiratory image, you can see air trapping, and specifically in that one lobule, again, air trapping because of an airway abnormality as the cause of this discrepancy in perfusion. Now, in hypersensitivity pneumonitis, we often see this combination of patchy areas of ground glass opacity and patchy areas of mosaic perfusion. And this combination together represents the head cheese sign, and it's very typical of hypersensitivity pneumonitis because hypersensitivity pneumonitis results in both lung infiltration, resulting in the ground glass, and airway obstruction, resulting in the mosaic perfusion. So that combination is the so-called head cheese sign. Ground glass opacity equals lung infiltration. Lucencies or mosaic perfusion equal the bronchiolitis and air trapping that occurs. Now, here another nice example of the head cheese sign in subacute hypersensitivity pneumonitis. And this is why I call it the head cheese sign. My grandfather came from Germany at the age of 16. Actually, he arrived in the United States on the same day as the San Francisco earthquake. But in any case, he lived nearby and spent time with him in the summer. And he always had head cheese. Now, this is what head cheese looks like. It's made of the chopped and boiled parts of the head of an animal, usually a hog. And this picture I have is from the days before digital cameras. And I went down to the deli and I bought some head cheese and I brought it back and I put it on my flatbed scanner. I don't recommend it, but in any case, when I was done scanning and getting this nice picture, I peeled it off, and I made the second mistake at that point, and I made it into a sandwich and ate it. And it sort of tastes like it looks. But in any case, head cheese has this very geographic appearance with some areas that are sort of white and some areas that are sort of black and some areas in between. And if I morph this head cheese to black and white, I think you can see the similarity in appearance between hypersensitivity pneumonitis and head cheese. And this is why it is called the head cheese sign, and very, very helpful in recognizing this disease. Here a patient, again, with hypersensitivity pneumonitis and patchy areas of ground glass opacity and areas of mosaic perfusion, so the head cheese sign again. And here expiratory images in this patient showing areas of air trapping in those lucent lung regions as we would expect. Here another example of the same thing, ground glass opacity and lobular areas of mosaic perfusion. Here air trapping on expiration as you would expect to see, typical hypersensitivity pneumonitis. Same thing again, 66-year-old bird fancier with progressive dyspnea, subacute hypersensitivity pneumonitis with both ground glass opacity and these lobular lucencies or areas of mosaic perfusion with air trapping on the expiratory images. Now here a patient with an inspiratory scan that looks basically normal to me. I'm not sure I could read this as abnormal. This is biopsy-proven hypersensitivity pneumonitis. The expiratory scan shows air trapping, even though the inspiratory scan didn't show much at all. So this is something you may see on occasion. Now, how about the chronic stage? Patients who have long-term or repeated exposure develop irregular fibrosis consisting of coarse scars and traction bronchiectasis and honeycombing in some patients. The fibrosis is patchy, and unlike idiopathic pulmonary fibrosis, it lacks a subpleural distribution most of the time. It is diffuse or predominant in the mid-lung zones, just like the subacute stages. The fibrosis occurs where the active disease is, and that's usually diffusely, or the mid-lung zones. Again, that's different than the interstitial pneumonias. Upper lobe involvement is quite common, and that would be very atypical for IPF. Superimposed findings of subacute hypersensitivity pneumonitis are present in some patients with fibrosis, so you can see ground glass opacity or centrolobular nodules mixed in with fibrosis. And basically, the head cheese sign with findings of fibrosis is what you might see. So here are a few examples. Hypersensitivity pneumonitis with progression to fibrosis. On your left, you mostly see ground glass opacity with some patchy areas of mosaic perfusion. On your right, you can see fibrosis is developing with some traction bronchiectasis, perhaps even a little honeycombing, but the ground glass opacity is still visible. And notice that the entire cross-section of lung is involved. It's not subpleural predominant. And here we're looking at the upper lobes where the disease is worst. Now here a patient with chronic hypersensitivity pneumonitis, a prone scan through the lung bases shows fibrosis and honeycombing. You might think that's IPF, but the upper lobes show extensive disease, upper lobe predominance, involvement of the entire cross-section of lung, and some areas of mosaic perfusion that lead you to make the diagnosis. Another example, extensive reticulation, but upper lobe predominance. And here a 2D image I showed you in my last presentation showing a mid-lung or a mid to upper lung predominance in this disease with relative sparing of the lung bases. Chronic hypersensitivity pneumonitis with reticulation and traction bronchiectasis. Here we see upper lobe predominance. The entire cross-section of lung is involved. There are areas of mosaic perfusion, so this is like the head cheese sign, but with fibrosis being present. So we're seeing not only fibrosis, but areas of mosaic perfusion and air trapping. Well, in summary, in my last talk, I talked about the interstitial pneumonias. In this talk, sarcoid and hypersensitivity pneumonitis. Taken together, these 5 things constitute most of the cases that I can diagnose correctly or suggest the diagnosis with a high degree of likelihood.
What I want to do is try to kind of complement what I did upstairs with the sort of the second half or the flip side of the coin, and that is not to look at the diseases that cause a lot of scarring and fibrosis in the lung, but to look at the diseases that end up causing a lot of nodularity. And what I want to do is develop an algorithm. Actually, the person who developed this initially was here earlier today, James Gruden. The idea would be to create some kind of algorithm. First of all, something I didn't get a chance to talk about, but I thought perhaps it would be worth just spending a second about, and that's how to scan people. And also to talk about differential science. It seems as though I skipped over that. If you have a multi-detector scanner, especially if you have a 16 detector, but frankly a 4 detector as well can do this, what we've been doing now systematically is using the thinnest collimation possible and scanning everybody that way, so that if you have 0.75, 1, 1.25, whatever your thinnest collimators are, depending on what kind of equipment you have, we scan everybody that way, single breath, top to bottom. And then as a routine, we reconstruct 5 millimeter thick sections using both edge-enhancing bone window, lung window. We use the thinnest collimation possible, and then we reconstruct 3, because most manufacturers allow you automatically to reconstruct 3 separate prospective series. So we do 5 millimeter thick sections with lung windows, 5 millimeter thick sections with mediastinal windows, but then we routinely also do 1 millimeter thick sections every 10 millimeters. That has the effect essentially of turning every study into a potential high-resolution CT study. And the notion of a standalone high-resolution CT study, which is 1 millimeter thick sections every 10 millimeters in most places, in a sense is an anachronism. The exception to that would be if you have someone you're repeatedly scanning over time and there's a question of radiation dose, and you really know what you're dealing with, you have an established diagnosis, and you're just looking for a response, and you're not worried about the development of a lung cancer, so now you're talking about a fairly small group. Mostly younger patients, say with sarcoid, or pediatric cases, obviously, for which you don't want to over-radiate, and for which a high-resolution, true high-resolution study with 1 millimeter thick sections every 10 millimeters would be requisite or adequate. Virtually all the rest of the time we do that, the thin sections with the routine sections, as a component of our study. The other advantage of that, and it's one that you probably don't experience mostly yourselves, but I think you can predict in the future will be part of all of our imaging environments, if you will, is that if you do all those 1 millimeter thick sections, you now have the capacity to start playing around with CAD systems, because CAD systems, all of them, and I'll have a chance hopefully to demonstrate one of them, all of them are basically based on the notion that the computer is better at looking at 650 or 700 1 millimeter thick sections than we are. And so it makes a lot of logical sense that we'd look at thicker sections and occasional thin sections, but the computer would also then look at all those thin sections. And it's not just for lung disease, it's really for everything. The only other options then, and there are several, just trying to remember off the top of my head, we do all of our cases supine. We do not routinely do prone imaging, although there are obviously cases where prone images of the lung bases make a lot of sense. If you think there's early disease in the lung bases, putting someone prone makes a lot of sense, but we don't do it routinely. The other thing that people will do, and there are some places that do this routinely, is a series of expiratory scans. We don't do that routinely, but there is no question whatever that doing expiratory images in the appropriate setting, someone where you think there may be air trapping or small airway disease, is an essential component. I know Rick Webb, for example, I think does routinely 3 or 4 expiratory images in every single case with just 1 millimeter axial images. We haven't done that. We didn't think the yield was high enough, but it's certainly something you should think about when you're looking at your images. And then one other thing to talk about in terms of technique, and that is low-dose CT. Because if you're really talking about trying to evaluate the lungs, especially if you already have somebody who's been evaluated with a good quality study, you can cut the MA down to 30 to 40 easily without sacrificing any detail in the lungs. And if you're going to follow patients, as we now do, I have scans now where I have 10, 11 follow-up CT chests. The pulmonologists are looking at CT like their chest radiographs. That's a huge amount of radiation. And the truth of the matter is, for most of the things I'm going to show you right now, it's absolutely not necessary. You can get away with cutting the dosage by 1/10 and still have perfectly interpretable images. So just by way of a little bit about technique. Okay, so we're going to talk about not all of these. We talked about reticular disease upstairs, really. I want to talk about nodules. And there's really a logic to how to approach this problem of diffuse nodular lung disease. And it's a problem that we encounter all the time. And if you follow the algorithm I'm going to develop, the chances of you getting to the right diagnosis really are substantially enhanced. It is a very practical thing that I want to share with you right now. What are the things you have to think about when you have someone who has diffuse nodules? Well, the first thing you have to decide is that, in fact, what you're looking at is a case with diffuse nodules, and I'm not being glib about that. It frequently is one of the most difficult things to do. One of the first steps for any of these images is to try to decide what you think the primary thing going on is. Is it diffuse haziness in the lung? Is it increased lines or reticulation? Are there nodules? And frequently a lot of these things will coexist. So you have to make a judgment about what you think the primary problem is and then use that as a point of departure. So having said that, if you think that nodules are the predominant problem, then what do you look for? Well, you certainly have the ability to look for the pattern of the distribution. Where are they? Are they related to the fissures? Are they related to the pleural surfaces? And as I'll show you, that's an essential part of this algorithm. What do they actually look like? Are they sharply defined, really crisp-looking little nodules? Or are they kind of hazy ground glass types of nodules? How profuse are they? How many of them are there? And then, do they have any kind of morphologic features? And specifically what I have in mind here is whether or not they have a tree and bud configuration, which is another essential thing to try to identify, feel familiar with looking at, and then use as a means for differentiating between the various entities that cause diffuse nodularity in the lung. So, real quick, let's just do lobular anatomy, because the key to this is going to be, in addition to looking along pleural surfaces and fissures, it's going to be remembering the anatomy of the secondary lobule. Because it is truly the one advantage over chest radiographs that we have when we look in cross-section is that we can actually define things in terms of the basic anatomic unit of the lung. So, very briefly, what's the secondary lobule? It's defined by core structures, as you'll recall. So in the center you have the pulmonary artery and its adjacent bronchiole, and then they ramify into capillaries and alveoli in the secondary lobule. And then along the edge of the lobule, secondary fissure here, if you will, but more likely called septa, interlobular septa, you have the veins and you have the lymphatics. When these things are up against the pleural surface like this, these tend to have right angle configurations. If they're in the middle of the lung, they can be hexagonal or polygonal in shape. Okay? So we talk about core central lobular or centrilobular distribution of pathology, and we talk about perilymphatic distribution, and I'll show you a million images in a second. But what we're talking about is the fact that there are some diseases that clearly center in and around the secondary lobular core, and there are some diseases that like to live along the edges of the secondary lobule. So what do we actually see? These are really kind of small structures. So the lobular artery itself is only 1 millimeter, and that's pretty much the definition of spatial resolution from most high-res C images. So what does that mean? That effectively means that we can see the central pulmonary artery. The bronchiole associated with it is the same size, but we generally can't see it because, in fact, you're not really seeing the pulmonary, the bronchus, because it's got air within it. So you're really relying on the wall to be able to see it. And obviously, if you look at these structures, 0.1 millimeter for the normal fissure and the normal interlobular septa, we're not going to be able to see those either. So in point of fact, a normal patient, when you look to see secondary lobular anatomy, it's actually very difficult to identify. What you'll see is a pulmonary artery that goes all the way out into the center of these lobules, but does not reach the pleural surface, which is the key to knowing that something is centrilobular. You may occasionally see a part of the septa, but oftentimes you don't, which means that if you look at most CT high-res images, you're not going to be able to identify secondary lobules. And that's the key. The key is that when you start to identify them, they're abnormal. And then it's just a question of deciding where the abnormality is in relation to this anatomy, right? So, ordinarily, what do you see? You don't look at this image, for example, and say, oh, I can see a secondary lobule here, because you can't. What you see is a pulmonary artery branching, reaching almost to the pleural, but not to the pleural surface. This is the central part of the secondary lobule. Same thing over here. One can imagine drawing, if you will, where a secondary lobule would be, but you don't see the septa, you don't see the veins, you don't see the lymphatics, you don't see the airways. Right? Okay, keep that in mind. All right, so here's the algorithm. It looks a little bit complex, but it's actually much more straightforward than you'd imagine looking at this. That's probably because I've looked at it 1,000 times. So, first thing is, as I said before, are you really dealing with someone who's got multiple nodules? Once you make that judgment, once you make that decision, then the next thing you have to decide is whether or not those nodules lie along the pleura and whether or not they lie along the fissures. Because the second you say those nodules lie along the pleura, you're no longer talking about a disease that's centrilobular. You're talking about a disease that is, in fact, involving the lymphatics of the lung. The lymphatics tend to run along the central axial core structures, so the axial interstitium, one more fancy word, which is the interstitium that surrounds all the major vessels and airways as they leave the hilum. That's called the axial interstitium, and you want to look at that very carefully. The other place where the lymphatics run are along the subpleural portions of the lung, and along the edge of the lung, and along the fissures. So if you have nodules that are stacked up along the fissures, if you have them stacked up along the pleural surface, then you're dealing with a disease that likely involves the lymphatics on some level. All right, so if that's true, then you're dealing with a lympho or lymphohematogenous process. Okay, if that's true, What's the next step for deciding what it is you're dealing with? Well, if that distribution of nodules is patchy, and if the axial interstitium is abnormal, if those central airways and central vessels are abnormal, then you're dealing with a pure perilymphatic disease. And I'll show you a lot of examples of this. Far and away, the thing that's going to cause that the most often is sarcoidosis. And it's one of the diseases that you really should feel very comfortable making a diagnosis without a biopsy, without anything else, just based on the pattern of distribution I'm going to show you. So, what is perilymphatic disease? Again, just to go over the same thing I've just said. Look along the pleural surfaces. Look along the septa and the interlobular septa. Look along the fissures. Look along these axial interstitial pathways. Look along the central vessels and the airways, because again, lymphatics run along them. Look along as well the centrilobular portions of the lung, but it's almost never going to be the case that sarcoid is going to be a predominant centrilobular pattern of distribution. Pathologists know this. If you hand a pathologist a whole lung mount with sarcoid, the distribution is going to be purely lymphatic. Those granulomas follow the lymphatics. It's also, by the way, why, if you talk about which diseases are most amenable to being biopsied by transbronchial biopsy, sarcoid's way up high on the list. Why? Because it lives in the walls of the central airways. That's where the lymphatics are too. So if you get into the central airways and take a small part of the wall, the likelihood you're going to grab one of those granulomas is really high. And if they're non-caseating, you make a diagnosis of sarcoidosis. All of this, by the way, totally predictable from the CT images. So, a couple of examples. What's the predominant problem here? I just showed you a whole bunch of cases with reticulation and honeycombing. That's not what's happening here. What's happening here are there are nodules all over the place, and they are clearly involving the pleural surfaces, right? They're also involving these central airways. Look at this bronchus and along its wall. Look at this bronchus down here and along its wall. Look at these vessels, and you can see they're literally beaded. Why are they beaded? Because that's where the granulomas are. Classic appearance of sarcoid. Notice that, in fact, they're clustered, they're tiny, they're poorly defined. There are whole portions of the lung that are not involved. Sarcoid tends to be a very scattergun kind of thing. It tends to involve the upper lobes, but you're not going to see diffuse total involvement of the whole lung, partly because of its perilymphatic distribution, but also partly because whole portions of the lung tend not to be involved. So if I just showed you this portion of the lung up here, you'd say it's perfectly normal. Again, what to look for? Look for interface signs. So typically the interface between the lung and the pleura is very smooth. You shouldn't see nodularity. Or look at this vessel over here, or this vessel here, or here, and notice how smooth that interface is, and then come down here and look at this guy. Same thing again, same patient. Where are the nodules? The nodules are along the pleural surface. Look at this. Is there any reason to doubt why bronchoscopists love this disease? Look at this airway over here. It's completely saturated with granulomas. So, what's the distribution? This is courtesy of Dr. Tesler. He's a pathologist friend from Mayo Clinic in Scottsdale. Where is the disease? It's along the pleural surface, along the axial interstitium, with areas of lung intervening, very nodular in distribution. The CT clearly demonstrates what the pathology is in the case of sarcoid. And again, if you look at it pathologically, these are central to the airways, clearly non-casing granulomas, all of them up against these airways, typical. Are there other diseases that are perilymphatic in distribution? Yeah, there's sarcoid, and there's sarcoid. There's silicosis, which can look for all the world like this. One need only ask, by the way, do you have silicosis? Lymphangenic carcinomatosis, you can get obviously nodules that are lymphatic in distribution, which is why it's on this list, but between the history and the pattern of distribution of this disease and ancillary findings, really it's a very rare case, if ever, that these two can be distinguished with any difficulty. It should be fairly straightforward. The one catch in all of this is miliary disease. You can have miliary disease that really does look a little bit like sarcoid, but even there, if you think about it, miliary disease is by definition much more widespread, much more random in distribution than typical sarcoid. So the bottom line is, if you can see the things I'm showing you right now, you're basically making a diagnosis of sarcoid. Add on to that those patients have adenopathy. Add on to that the clinical history typically is fairly convincing. And this is a disease that we really should be able to diagnose. So just more examples of the same. Lots of nodules. Again, you have to make a judgment that you're dealing with nodular disease. This particular case, along the fissure, maybe not so compellingly along the pleural surfaces, but along the airways, along the vessels again, clearly someone who has this pattern of distribution is perilymphatic. These things can cluster into like almost a sandstorm. And again, the distribution tells you along the pleural fissure here, again, clustered along vessels and so forth along here. Sarcoid tends to be more upper lobe than lower lobe, which is another key to the diagnosis. So typically you're going to see much more of a perfusion of these things in the mid and upper lung fields, much less of it in the bases. Now, obvious point, and this pretty much pertains to all lung diseases, and it's not made clear enough in most lectures. Most of these diseases don't actually have a static appearance. Sarcoid's a great example of this. Hypersensitivity Pneumonitis is a great example of this. Typically, an early case of sarcoid, you get these potato nodes. If you look at the lungs, they can be perfectly normal. Then you get more and more involvement of the lungs, then the nodes become smaller, and you end up with scarring in the lungs. So what I'm showing you is a characteristic appearance when the predominant abnormality in sarcoid is, in fact, all of these small nodules. But keep in mind, you're dealing with a spectrum of disease always, for all of these. Just more examples of the same. Normal lung up in here, clusters of these small airways, nodular changes along the airways, nodular changes along the fissure. Look at this vessel, for example. You know, pathologists do the same thing. If you show a pathologist a slide, they don't look at the whole thing. They try to pick out along the edges the one or two characteristic cell, characteristic area of abnormality that tells them what the most likely diagnosis is. And the same thing is true for us. Look carefully along the axial interstitium. You don't need much more than this one area right in here to make a diagnosis of sarcoid. Again, the same thing. These are all basically the same pattern of nodules, are perilymphatic in distribution, clustered. Sometimes these things can coalesce into larger masses, can almost look like progressive massive fibrosis with these big, large masses that occur in the upper lobes. And you can have these break down. Occasionally, cavitary sarcoid is something to be concerned of. So you get these kinds of more fibrotic changes, but they don't really look like the IPF cases I showed you upstairs. So where are they? First of all, they tend to be more upper lobe than lower lobe. You can see these distorted airways, but again, even here, look along the edges, and you get the sense that you have all these small nodules all over the place, clustered in here, more of a conglomerate mass, typical of a much more severe case of sarcoid. But again, this pattern still should be very diagnostic of that. So it's perilymphatic, it's clustered, tends to be more upper lobe. People talk about ground glass attenuation in sarcoid. It's rare. What you're really looking at are just this conglomeration of small nodules that give you kind of a haziness. If you look really carefully, you'll see you're looking at small nodules. What about the lobular septa? I made such a big stink about that. Interestingly enough, the distribution of sarcoid is not characteristically along the septa, even though that's where the lymphatics run. So, for example, if you look at any of these cases, does anyone see a secondary lobule here? Does it jump out at you? The answer is no. And the reason is because, for whatever reason, these nodules tend to be along the pleural surface, along the axial interstitium, and they tend not to be primarily involving the septa. Why is that important? Because that's what you see in lymphangenic cancer, and we'll show you examples in a second. Again, more clustered disease, more massive, but again, look at these airways, huge nodes along the fissures, nodules along the pleural surface, really kind of clusters of ill-defined nodules, some of them conglomerate. This is not cancer. The one thing you have to be a little wary about in sarcoid is these patients can get TB, so if you start to see cavitation, you do have to be aware you can have sarcoid and TB together, especially if you work at Bellevue Hospital. Upper lobe distribution, the lung base is spared. Again, you should have no problem differentiating this with IPF. Just as a parenthetical thing, there was a really important study that was done in the University of Arizona some years ago, where they looked at a registry of everyone with diffuse lung disease. By far, the two most common diffuse lung diseases are IPF and sarcoid. They account between them for almost 80–85% of all diffuse lung disease. So if you just close your eyes and guess one or the other, you're going to be right most of the time. Just not to put me out of business, but Same idea, kind of like gilding the lily here. These are all should become very familiar in your mind's eye. You should be able to pick out the nodules, pick out their distribution, and say, yeah, this looks like a sarcoid. Again, all of these showing basically the same phenomena. Let me show you a really subtle case, because they can be very subtle. Notice that most of the lung here looks perfectly normal, but look along this fissure, it's nodular. And then look along this one airway coming down here. Look at this airway here, or here. This small cluster of nodules here, and this is almost the only disease in the lungs, but it's unequivocal what you're looking at when you see it. It has all the characteristic findings of sarcoid. Alveolar sarcoid, what's that? Well, if you can imagine a cluster of these small things, again, a typical distribution, but you can imagine these things clustering to the extent that on a chest radiograph, they're going to look like vague areas of nodularity. You may even see air bronchograms in there. It's classic for what an alveolar sarcoid pattern is, but if you look at it in cross-section, it really doesn't have anything striking about it except for this clustering effect, which we've already seen against sarcoid. Really diffuse. So someone will look at this and say, ground glass attenuation. It's really not ground glass attenuation if you look carefully. It's just a million little nodules all over the place. And sarcoid can, because it involves the central airways, cause air trapping. So that's well described. If you see these kind of zones of now what you're actually seeing are secondary lobules. Here's a classic out here. You're seeing it not because there's disease along the edge. You're seeing it because the airway to that secondary lobule has been clogged up. So again, look for that. Expiratory images in sarcoid, you really don't need them in the vast majority of cases. End-stage disease, you get these kind of real clustering of mass-like effect, the so-called progressive massive fibrosis effect, but almost invariably you'll still see telltale signs of sarcoid with these wispy little nodule clusters all over the place. So, we're still on that one edge of the algorithm where we're talking about lymphohematogenous disease, and we're on the whole, way off on the left. And I said all of that's going to be sarcoid, but we'll talk a little bit about lymphangenic cancer because it involves the lymphatics. It's a perilymphatic disease. But it doesn't look anything like sarcoid. So very briefly, one of the key characteristics is that now you do pick out the secondary lobules because the lymphatics in them get all clogged up with tumor. And when they get clogged up, you start to see them. They can be either smooth or nodular, more frequently nodular. And it really does in its own right distinguish it from most cases of sarcoid. It's asymmetric, it's basilar because it's hematogenous. As you know, lymphangenic cancer is hematogenous, so the stuff goes down, not up. And then effusions, and by the way, the patient has cancer. Can you have cancer in sarcoid? Yes. Does anyone know what kind of cancers cause lymphangenic cancer? Breast, what else? Lymphoma, very rare. Prostate. The answer to the question is adenocarcinoma, as a matter of fact. Breast, lung, GI tract, all the adenocarcinomas are the ones that do it. So squamous cell carcinoma very rarely, if ever, causes a lymphangitic pattern in the lungs. So what do you see? Well, you see nodules, because this is hematogenous and lymphatic disease. Here's a nice vessel reading right into that. But what you see is haziness here and these lymphatics. And now you start to pick out secondary lobules real quickly. And the reason you can pick out secondary lobules is because the lobular septa are thickened with tumor. So if you look carefully, what strikes you here, there is haziness, maybe even a little reticulation, but nodules and lymphatics, secondary lobular changes. Sometimes you can see these all the way from the periphery to the hilum, representing obstructed, tumor-filled lymphatics, edema in those lymphatics and perilymphatic spaces. So what's the thing that strikes you here? It's all these secondary lobules. Look at these things. They jump out at you. You can't see these in a normal lung. But when you start seeing these, don't think sarcoid. This has absolutely no relation to sarcoid at all, even though it's, quotes, a lymphatic disease. And if, in fact, you look at this pathologically, that's what you see. Here's a secondary lobule. The septa where the lymphatics run are nodular, they're beaded, and you can actually see this running all the way along the septum here, the fissure, all the way to the central hilar regions. Classic for someone who's got lymphangenic carcinomatosis. All right, so if you have nodular pleural fissures, lymphohematogenous, if it's patchy, if the axial interstitium's involved, upper lobe, think sarcoid. Okay, what if, in fact, you have disease along the pleural surfaces, but it's much more diffuse, and the axial interstitium actually looks normal? Well, then what you're really dealing with is a random distribution of these nodules. And if you think about it, random distribution of nodules, some of them by definition will be along the pleural surface. Some of them will be along the fissures, and so that's why you're on this side of the algorithm over here. But it's not going to look like sarcoid. So what do you see with random nodules? By far, the characteristic etiology of these are hematogenous mets. That's really the classic. And the other thing you would have to think about is true miliary disease. They're both hematogenous, almost purely hematogenous. So hematogenous sarcoid, because it can do anything, but rarely does it do this, and miliary disease. And what do you see? Well, you'll see nodules along the pleural surface. You'll see occasional nodules along the fissure, but they're really much more randomly distributed. They tend to be a little more involving the lower lobes because it's hematogenous. There may be a couple of small nodules along the axial interstitium, but it's not a primarily axial interstitial distribution. And the nodules for both hematogenous disease and miliary disease, for the most part, aren't those kind of little fine, little gravelly things that you see in sarcoid. They're much better defined. So that's hematogenous disease. Doesn't look anything like sarcoid, obviously. And sure, some of them are going to be subpleural, and occasionally they're going to be along the axial interstitium, but they're clearly random in the sense that they're pretty much everywhere. They're sharply defined. Some of them clearly are related to vessels, as shown here, and no one in his right mind is going to look at this and think anything other than hematogenous metastatic disease. The more you get, the more likely it is that some of these are going to be subpleural, some of them are going to be along the axial interstitium, but again, well-defined, slightly variable-sized, randomly distributed through the lung. There is a lymphatic component to these, but this is hematogenous disease. So smooth, well-defined nodules, random or uniform, typically more lower lobe. You may see feeding vessels. Of course, they're metastases for the most part, so you can see cavitation. And you may see features of lymphangenic carcinomatosis, because remember that lymphangenic carcinomatosis is hematogenous disease, so you might expect to see some overlap. So here a patient with, again, I think no one would question this being sarcoid, and there is a perilymphatic distribution in the sense that they're against the fissures and the pleural surfaces. Again, just a profusion of these nodules. This is where it gets harder. I mean, the other ones are fairly obvious, but what about something like this? Well, again, there are well-defined nodules, but while some of them are up against the pleural surface, these are really random. This doesn't look like the sarcoid I've shown you. They're all over the place. They're kind of almost scatterguns throwing them into the lung. This is somebody with miliary Tb. And what about a case like this? It gets even a little harder because the nodules here aren't as well defined, but they're clearly, some of them are subpleural in location. The predominant abnormality here is nodules, but again, they're all over the place. This is in fact metastatic disease. This is renal cell carcinoma. History helps. Someone who's got miliary disease, for the most part, that patient's going to be pretty sick. Not invariably, but pretty often. Someone's got renal cell carcinoma and shows up with this, you're not going to think sarcoid either, right? One of the things that kind of fascinates me about all the studies that we have in our literature, by the way, is invariably, or almost invariably, the way the papers are written are, some radiologists, a group of radiologists, have shown a bunch of cases without clinical history and asked to see whether or not they can make a diagnosis. Does that make any sense to anybody? Because it's never made any sense to me. I mean, the real measure of whether or not what we're doing is effective or not is if we have all the information that we're supposed to have and then try to figure out if you can figure out what you're looking at. Anyway, so much for that rant. Perilymphatic sarcoid, random nodules, and again, I think once you see them side by side, really straightforward, okay? Just another example of the same, perilymphatic and random, just to make the point of how variable and really different these things really are. Okay, you don't have, doesn't that sound good? You don't have nodules along the pleural surfaces of the fissures, or they're not the predominant finding. Well, now what? Well, if they're not along the pleural fissures, and the reason I went in all that detail about the secondary lobule is that they're now going to be centrilobular. And the hallmark of centrolobular disease is it doesn't reach the pleural surface. So if you have a whole bunch of nodules, but in fact none of them are along the fissures and none of them along the pleural surfaces, don't think along this line. Start thinking over here. So what are our choices on this side of the equation? Well, there are really two different breeds of centrilobular nodule. There are the kind of amorphous, hazy, ground glass nodules that you frequently see in a whole host of diseases, or they actually have a shape, and the shape that they have, or the configuration, or the morphology they have, is so-called tree and bud. That's the critical question, okay? If you can see axial disease, think sarcoid. If you see tree and bud, think infection. Because the only thing that really causes this, for all the occasional case reports that you read, the only thing that really causes a tree and bud pattern in the lungs is infection. So, centrolobular disease. You can have disease that looks relatively round, or you can have disease that looks so-called tree and bud. And we'll show you better pictures than this. Nothing in the axial, nothing along the fissure, nothing along here. These can be clustered, or they can be truly diffused through the lung, and that's something else you're going to want to look for. So, ground glass nodules, these guys, can be a lot of things. They can be true disease that affects the centrilobular bronchiole, or it can be peribronchial or even vascular. In other words, anything in the center of the secondary lobule, by definition, is going to be related to the airway and going to be related to the vessels. So if you have poorly defined, poorly marginated little nodules that are centrilobular, it can be either airway, it can be vascular in etiology, okay? On the other hand, if you have tree and bud, now you're talking about something that's truly bronchiolar, because tree and bud implies something's branching. And the only thing that branches in the central portion of the lobule that you're going to see as a branching structure is, in fact, an inspissated small bronchiole filled with secretions. So, look at this, and you say, all right, random distribution of nodules, right? Except they don't reach the pleural surface. And then you see that, in fact, some of these things have a linear configuration with dots along the course. You see that there? Here's another one. Get to feel very familiar with this. This is your friend. This is an incredibly important finding in high-resolution CT, because if you can make that diagnosis, if in fact most of what you're looking at conforms to that tree and bud, you can be very precise that what's causing all the rest of this stuff is infection in the lung. It doesn't tell you what kind of infection. It could be TB, it could be MAI, it could be bronchial pneumonia, viral pneumonia, any kinds of infection, all of them that end up with infected, inspissated secretions in the small airways is going to look like this, and virtually nothing else does. So you really want to be able to pick it out. Now be careful, because other diseases may have an occasional kind of tree and bud appearance. But if you can pick these out really easily, like picking out secondary lobules can be real easy when you really see them and know what to look for, now you're talking about pure bronchiolar disease. Two examples, more of the same. This guy's real obvious, right? This is all endobronchial spread of TB. By the way, the classic example of this is endobronchial spread of TB, because what's happening, you have a cavity, erodes into an airway, goes then into the rest of the airways, lodges out in the periphery of the airway. What do you get? All these inspissated small bronchioles filled with secretions, hence tree and bud. So take again, not along the pleural surfaces. Look at how smooth this vessel is, by the way. There's absolutely nothing involved in the axial interstitium here. Virtually all of these things represent tree and bud. Frequently, not surprisingly, if you have peripheral small airway disease, you're going to have central airway disease. So not at all infrequent. Another sign that you're dealing with infection in the airways, look for bronchiectasis. So a lot of these patients are going to have bronchiectatic airways. But again, look along here and realize that the reason why you're seeing this pattern down here is because these bronchioles are filled with secretions. And they get kind of dilated and they run alongside the vessel, so you're going to see a branching structure and you're going to see little nodular excrescences along it. That's why you see this. So, you have sometimes some problem doing coronal MIPS, coronal reconstructions, by the way, very frequently are helpful, because what might not look like an axial distribution, a tree and bud, when you do a coronal image, unequivocally becomes tree and bud. Again, all of these, I mean, once you've learned to look for these things, they really just stand out. And these central airways, by the way, are a little dilated. And why do you see this pattern? Well, if you do a bronchogram, you'll see why. These airways don't reach the pleural surface and they branch. So you can imagine filling these guys up with secretions next to a bronchiole, next to an artery. That and that are the exact same thing. Just more examples of the same, really gilding the lily. So this is an old study. Actually, probably needs to be repeated because it's almost a decade old, but I would swear by this because it's been our experience. Retrospective evaluation. This is Gordon Gansu's work with Susan Aquino. Looked at all different kinds of airway diseases, so bronchiolitis obliterans, BOOP, extrinsic alveolitis, respiratory bronchiolitis, bronchiectasis, so forth. They found tree and bud in about 15% or so of patients with pneumonia, a whole bout, frequently seen in bronchi, not seen with anything else. Well, these are all infectious etiologies. So again, when you see this, think infection. Okay, so you have nodules that are centrilobular, but they don't have a tree and bud configuration. So now we're all the way over here. So diffuse ground glass nodules. Now, this, as I just finished telling you, could be related to the centrobronchial or peribronchiolar or even perivascular. Occasionally, very rarely, pulmonary edema can give you centrilobular nodules. But it looks very different than what I just showed you in terms of tree and bud. And there's a whole host of differentials that you have to think about here. So, does this look like sarcoid? Does this look like lymphangenic cancer? Does it look like IPF? Does it look like anything I've shown you up to now? No. What are we dealing with? We're dealing with poorly defined ground glass nodules everywhere, virtually everywhere. None of them along the pleural surface, none of them really along the fissure. Here's one, here's one, there are literally innumerable of these. Poorly defined ground glass nodules uniformly distributed through the lung. Differential is hypersensitivity pneumonitis. Subacute hypersensitivity pneumonitis at that. Almost invariably, this pattern is hypersensitivity pneumonitis. All of those. And once you've seen one, you've seen them all. So these are two patterns of centrilobular disease. Over here, classic tree and bud. Over here, classic centrilobular ground glass nodules. This is hypersensitivity pneumonitis, and this is a viral pneumonia. By the way, if you do a transbronchial biopsy in this guy over here, you're not going to get anything. It's a complete waste of time. I mean, unless you have a central cavity and you think you might be dealing with TB, but otherwise, this pattern, what you'll come back with is nonspecific inflammation. Almost invariably, these patients come with, they're on antibiotics. By the time you get to them, you're not going to make a specific diagnosis. Here, you don't need to do a biopsy. And why is that? Because hypersensitivity pneumonitis is a disease that, in fact, can be made clinically. If you have the right history, you go back and, does anyone really raise pigeons? But apparently they do. We see them several times a year, but there are drug reactions that can do this and so forth. We go back and say, listen, and you're the first person who's going to make this diagnosis, because these patients all come with the same symptom. If you haven't noticed from pulmonologists, you can't breathe, you're coughing, maybe you're coughing up blood, you have chest pain. Did I cover it? So, by definition, you're going to be one of the keys to suggesting disease. And this is a disease that you can actually suggest. You get precipitants from the blood and so on and so forth, and you really can make this diagnosis without a biopsy. So, HP, it's actually an inferential diagnosis, exposure history. You can have antibodies to the antigens, although it only tells you've been exposed. You can do inhalational challenges, but notice what's absent here is a biopsy. Again, once you've seen one of these things, I mean, they really almost look the same. One of the things about hypersensitivity pneumonitis, and I showed an example of IPF earlier that actually mimics chronic or subacute / chronic HP. If you look carefully, again, you see all these poorly defined ground glass nodules? So this is characteristic of HP. The other thing that's characteristic of HP is that you tend to have sparing of secondary lobules. It's not that the lobule septa are thickened, it's just that for whatever reason the antigen didn't reach this particular bronchiole, and so this particular secondary lobule was spared. This secondary lobule was spared. If you see ground glass nodules or haziness like this with sparing of secondary lobules like that, think again about hypersensitivity pneumonitis. These things can be really profuse. But notice that hypersensitivity pneumonitis is not a disease that clusters like sarcoid, or clusters, for that matter, like these inspissated small airways. I showed you examples of infection in airways that are very diffuse, but you can have that very clustered, just one little area of the lung was, for whatever reason, those airways became infected. So mixed bronchiolar disease, common subacute hypersensitivity pneumonitis. The other thing, which I didn't get to upstairs, but I'll get to right now, is respiratory bronchiolitis, interstitial lung disease. This is a very trendy thing to talk about. It's a smoking-related disease. And very early on, with respiratory bronchiolitis, what you'll see on a CT scan are a few, and I mean few, poorly defined ground glass nodules, centrolobule nodules in the upper lobes. And you'll wonder whether or not you're dealing with something called AAH, or atypical adenomatous hyperplasia, or you won't even think anything at all about them, and that's probably a good thing not to think anything at all about them, because they just mean that you're dealing with a smoker, and it probably shouldn't be overread. But that same entity can then become a diffuse interstitial lung disease, so-called respiratory bronchiolitis interstitial lung disease, which is one of those alphabet soups that I didn't get to because, frankly, you can wait a couple of years before you'll see one, and you're not going to make the diagnosis anyway. The pathologist is going to make it. The other thing you might want to think about, and I'll show you some examples, is Langerhans cell histiocytosis, and that'll pretty much cover most of the important diffuse lung diseases you're likely to see. Sarcoid, well, again, sarcoid can do anything, but you can count the number of times you're going to see this pattern in sarcoid. Lymphoma can do this. Be aware that, again, you have some lymphatics that can, in fact, occur in the central portions of the lung and give you diffuse nodules, but it's really very rare. What you're really dealing with is what's called bronchial-associated lymphoid tissue, which can become then a maltoma or a balltoma or lymphoma, not very frequent. So patients such as this, this actually is a patient who has lymphoma. These are all poorly defined ground-glass nodules, and you might think in terms of this patient having a hypersensitivity pneumonitis. But when that was ruled out, we were left with saying, well, we're not sure what it is, but this patient had known lymphoma. Patient had open lung biopsy, and sure enough, there are these lymphatic aggregates adjacent actually to the vessels in this case and to the airways, which is why you see this pattern translated to this. And this is somebody who has lymphoma, but I have like 3 cases of this in the last 20 years, so I wouldn't worry about it too much. Respiratory bronchiolitis. A lot of people talk about this, hot topic. I don't know why it's part of that alphabet soup, because this is a smoking-related disease. It's not idiopathic. What you get is these pigmented-laden macrophages that first start out in the central small bronchioles, but can occasionally incite some reaction around it and then can, in fact, involve the entire lung. And so what you're really dealing with is this spectrum of respiratory bronchiolitis to respiratory bronchiolitis, interstitial lung disease, to desquin of interstitial pneumonitis. It's really all the same disease. But it's a spectrum of severity, and it occurs in smokers. So what do you see? You see these kind of ground glass nodules, but this is a patient who, in the absence of anything that would go along with a hypersensitivity pneumonitis or any other known etiology, if you find this is a smoker, this patient's going to have an open lung biopsy anyway. But just thought I'd show you a case of respiratory bronchiolitis. Another case of respiratory bronchiolitis, again, you get these poorly defined little nodules, some ground glass. Here actually making a distinction between kind of patchy ground glass attenuation and nodules really is pretty subtle, because when you get to the point where you no longer just have disease in the bronchioles, you're really talking about a more diffuse pattern, and you're not going to know what these is, so you're going to end up biopsying them. But the truth of the matter is, again, it's a rare entity in my experience. So this is what it looks like when you see it more diffuse. And then there are cavitary nodules, just to keep that really quickly so we can finish this up. It's kind of a separate set of category, and I think most of you know what those are. Septic emboli is probably the most common one. Nodules in various stages of cavitation. No one's going to confuse this with anything I've shown you up till now. You can occasionally see these little donut signs, and this is somebody who has diffuse alveolar cell carcinoma. So if you see these are not airways. These are obviously nodules. They're in a random distribution. And if you see kind of like these little cavitary changes in them, think in terms of bronchoalveolar cells. So these are, I'm just kind of like finishing off the edge, if you will, polishing the subject. But these are all rare entities, and I wouldn't worry about them.
Good afternoon, everyone. My name is Nader Kamangar. I'm joined here today by Dr. Robert Su, who's the professor of radiology at UCLA, as well as the residency program director for the radiology residency at UCLA, as well as the director of interventional radiology there. This is an interactive session, so there are embedded questions that you're going to see, and we're going to be asking for you to actually use the audience response system as we go through these questions that will lead up to specific areas that Dr. Su will be highlighting. So please make sure when we get there to all vote. So without further ado, Rob?
Great. All right. Thank you all for coming. Thank you, Nader. All right, so, okay, so when looking at a high-resolution CT, it's really important to keep the pathology-based terms clear and distinct compared to the pattern-based terms. So the pathology-based terms are really what's reflected on pathology. So these are going to be entities like UIP, NSIP, LIP, AIP, organizing pneumonia, desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, and Langerhans cell histiocytosis and lymphangial leiomyomatosis. The pattern-based terms, on the other hand, are kind of a bird's eye or airplane view of what's happening at the pathology level, or what we're seeing on CT. It's just a reflection of what's happening on the pathology. So these terms are going to be a little bit vague, but for lack of better, these are kind of descriptive findings, such as reticulations, nodules, cysts. And there may be some terms like heterogeneous attenuation, so that there's alteration in the lung parenchyma. And you'll see terms, and we'll go over this: mosaic attenuation, airspace attenuation, or consolidation. And this can be in the form of heavy ground glass or just ground glass, and true airspace consolidation, where you can't see the underlying lung structures. So the patterns that we're going to discuss this afternoon are simply reticulations, nodules, cysts, and airspace disease, and some of the common entities that display these sort of radiographic patterns. So under reticulations, you have mostly the interstitial lung diseases, UIP, NSIP, chronic hypersensitivity pneumonitis, the nodules pattern, or the nodular pattern, and we'll go through a number of these patterns, but clinical entities would be sarcoidosis, metastases, more of the airway-borne things like subacute hypersensitivity pneumonitis, cysts, as we kind of mentioned, those two entities, and airspace, or predominant airspace disease in the form of organizing pneumonia and DIP.
So our first case is a 77-year-old man with a 3-year history of progressive dyspnea on exertion. The cases are intentionally kept brief so we can get through more. So you're going to see a few axial images. And a coronal there.
And then I'll go back through them.
So what is the most likely diagnosis here? Is this NSIP, asbestosis, idiopathic pulmonary fibrosis, or chronic hypersensitivity pneumonitis? Please vote. Great, 94. So you guys all have this down. I would just
Session's over.
Yeah. I think just although only 1% selected it, just to recognize that asbestosis could have very similar features. I mean, what are we seeing here? The predominant features we saw here is a reticular pattern that is more lower lung field peripheral predominance with reticulations, honeycomb changes, traction bronchiectasis and bronchiolectasis, and minimal amount of ground glass. Asbestosis would not be inappropriate here if there were other features of asbestos-related lung disease like pleural plaques, rounded atelectasis, and a clear history. So that's the only other answer that could make sense with the appropriate additional findings.
Okay, so obviously we're in the first sort of gamut, which is reticulations. And again, we talked about, briefly mentioned UIP, NSIP, chronic HP, and the clinical entities that this may represent, IPF, collagen vascular disease, drug toxicity, or maybe in some cases asbestosis, or diseases that might give you reticulations. So when dealing with reticulations, it's important to look at the differentiating features. And so you'd like to know what the distribution of those reticulations are. Is it upper versus lower, central versus peripheral, segmental versus diffuse? Is it the pattern that you're seeing a heterogeneous pattern? Is it a more homogeneous pattern? When you compare right and left sides, do they kind of overlay or mirror one another, or are they very different? You also want to look for honeycombing, subpleural sparing, ground glass attenuation. And there may be some other clues on the film that give you maybe some idea or maybe a cue as to what the patient might have in terms of ancillary findings. So with asbestosis or asbestos exposure, you might look for pleural plaques. You might see arthropathy or dilated esophagus in some of the connective tissue diseases, as well as subcutaneous calcifications. In the setting of amiodarone toxicity, there may be a hyperdense liver or thyroid. And certainly, history is hugely important to help narrow the differential diagnosis or at least figure out what the pattern may be representing. So as you all know, UIP pathologically is characterized by temporal and spatial heterogeneity, and the characteristic or most distinctive feature here is the fibrogenic foci. Now, the CT features, the most common things that you'll see are going to be peripheral reticulation with a basilar predominance and honeycombing, if you see it, and you see it in generally 60 to 70% of the cases. There is not too much consolidation, but again, lower lung predominance, right? So here's just an example of a classic case of UIP, and this sort of classic presentation, or what we call consistent with UIP pattern, is seen in about 50% of patients. So here we see from top to bottom, you can see that the disease is predominantly subpleural, predominantly basilar. It's characterized by lines, reticulations, and certainly there's a huge degree of honeycombing. And honeycombing, if there's nothing else that you take away from this session, is that honeycombing is characterized by, again, these sort of thick-walled, polygonal, hexagonal structures, but within the actual area or the center of that is air density, not gray lung, but really black air density that's similar to the air that's, for instance, within the trachea or the larger bronchi. And that's really the true definition of radiographic honeycombing. So here we see just some additional images. And again, these are true honeycomb cysts. Again, very thick sort of inter and intralobular septa, irregular, and within the center of that area is clear air density, not more gray density of lung. And here we see the histopathology that goes along it. Again, the thickened septa. We see the fibrogenic foci and the honeycombing. And again, the gross specimen that the CT images reflect. Here's kind of the natural progression of what we see in IPF, UIP. And again, this is over 2 years, so it's a sort of a slow but stepwise deterioration over time. You see areas of coarse ground glass and reticulation ultimately becoming honeycombs, and with increasing architectural distortion and traction bronchiectasis and bronchiolectasis. So in 2009, Song looked at or tried to compare those patients with connective tissue or collagen vascular disease, UIP, versus those with idiopathic pulmonary fibrosis. They looked at 100 patients and found that the ones with UIP with collagen vascular disease largely were younger, women and non-smokers, and was associated with better survival. They had less fibrogenic foci, less honeycombing and honeycombing spaces, but had more germinal centers and inflammation, and they coined the term atypical UIP without honeycombing. The germinal center score was the best discriminative factor of distinguishing these two diseases, and age, total lung capacity, and honeycombing were independent sort of prognostic factors for improved survival. So here we just have a couple cases. All are path-proven UIP. And here we see a person with a dilated esophagus, and again, this is what I mean by looking at these ancillary findings for clues, but you see, again, a basilar predominant disease, reticulation, and honeycombing, and with a dilated esophagus, this was diagnosed as scleroderma. On your right, on the top, we see another patient with UIP, but notice, again, you see the dilated esophagus, but not quite the honeycombing, and you see a lot more ground glass in this case. And so again, not your classic UIP pattern, and the degree of ground glass may make you think it's something altogether different than UIP, but again, this turned out to be scleroderma lung disease with UIP. On the bottom, we see more ground glass attenuation, and you see that there's a lot more ground glass than the reticulation that we see here. And again, it is a subpleural predominant disease, and not much honeycombing, as you can see. And on the soft tissue windows, look what you see, a little pericardial effusion, and you see soft tissue calcification. So this is a patient with dermatomyositis with lung disease, again, path-proven UIP. So the UIP that we see with collagen vascular disease may be somewhat different, or it often is very different than the UIP that we see with IPF. So let's look at some of these sort of more unusual features of UIP. IPF. So sometimes you'll see a ground glass predominance, as you see in this top image here. Again, the ground glass is a lot more than the reticulation, or outweighs the reticulation. There may be asymmetric involvement on this bottom image. You see that the left lung is more considerably involved than the right, and there's not so symmetric. You might see areas of focal air trapping, which again is not uncommon but unusual for UIP IPF. You may see areas of pulmonary ossification, and so I don't know if it projects very well, but you see little hyperdense nodules within the densest areas of fibrosis on the bottom image, and these correspond to areas of pulmonary ossification. And these are the fibroblasts undergoing metaplasia from chronic inflammation to become osteoblasts and laying down bone. In 90% or more, depending on which series you look at, those patients with IPF, UIP have what we call small to medium-sized lymph nodes, and so these are diameters, short axis of 1 to 2 centimeters, and again, it's a reactive phenomenon. And in about 10 to 15% of patients with IPF, you have an accelerated deterioration or exacerbation. So here's a case that had just pretty much reticulations on the initial or baseline CT, but during the exacerbation, you can see an extreme amount of ground glass that has come about involving all lobes and almost all portions of the lung. This was a case of sort of AIP on top of the UIP that happened. Here we see sometimes when you're dealing with patients with very diffuse lung disease, common diseases are sometimes very difficult to tease out. And in this situation, the only clue as to the diagnosis here is if the sort of astute observation of small symmetric pleural effusions that you can see. And this was a case of somebody with idiopathic pulmonary fibrosis with a congestive heart failure exacerbation represented by the pleural effusions and small pericardial effusion. These patients, as you all know, are susceptible to infection. Here on the top image, we see a necrotizing pneumonia with a bronchopleural fistula and a pneumothorax, air fluid level within the destroyed lung. On the other side, in the left apex, you see a mycetoma. You see a more classic kind of consolidative pneumonia in this bottom patient, in the right middle lobe, and in the left lower lobe. And as you all know, these patients are susceptible to lung cancer. And here's the same patient, a more superior image. You see a spiculated nodule in the left upper lobe, as well as one in the left lower lobe. This was a case of synchronous lung cancer in somebody with pulmonary fibrosis. And certainly, you can have air leaks or barotrauma. And so here you've got pneumomediastinum, and you have some a left pneumothorax, as you see in this case down below. That brings us to our next case.
So this is a 42-year-old with a 1-year history of progressive dyspnea with mild exertion as well as a chronic cough.
I just like the bigness of these images, right? Like so many talks, you see little images.
So what do you guys think? What is the most likely diagnosis here? Is this NSIP, asbestosis, IPF, or chronic HP? Please vote. Outstanding. So 2/3 of you got this right. And that 1/3, I think, is not entirely wrong. But what we're seeing here on imaging was a reticular pattern with a considerable amount of ground glass attenuation. The ground glass attenuation and the reticulations, although more lower lung field, were actually very peri-bronchovascular along the bronchovascular bundles, or the axial interstitium as we call it, with actually some areas of subpleural sparing. There was also some degree of traction bronchiectasis as well as bronchial wall thickening. So chronic hypersensitivity pneumonitis would more often give you a reticular features with areas of mosaic attenuation and air trapping, and that Rob will go over in a bit. But really this was most consistent with NSIP.
Okay, so we're still in the gamut of reticulations, and so we'll talk a little bit about NSIP. So unlike UIP, the pathologic features can be divided into cellular and fibrotic NSIP, and again, unlike UIP, we're going to see a temporally and spatially homogeneous disease with a lot more inflammation without this characteristic fibrogenic foci. There's not too much architectural distortion, and certainly almost no honeycombing. What we see on CT is predominantly ground glass admixed with reticulation of variable severity, and it, in many cases, will spare the subpleural periphery, or the very edge of the lung, in about 66% of cases. And so this is what so here we see, again, we see a more axial disease, meaning the center of the lung is involved, or the center of the lobe. And we see a lot of ground glass, and the ground glass outweighs the degree of reticulation here, right? So what we're seeing is more of this sort of dense gray lung. And what you can see is by subpleural sparing, we mean that the entity comes up to the subpleural lung, but just has a ribbon of where the lung is not involved. And with NSIP, this is probably the most characteristic finding that we see, and we see it in about 66, 65%, depending on what study you look at, of the time. It's predominantly a lower lung disease, and as the fibrosis progresses, you'll see more architectural distortion, you'll see more traction bronchiectasis. Now here's a different case, and here we can again see the ground glass admixed with the reticulation, favoring the lung bases and posterior periphery. But note again that we see kind of that characteristic subpleural sparing. And so if you see this, it's very good for NSIP. If you look at a cellular NSIP case, it's often very steroid responsive because of the intense inflammation associated with this entity. And you can see that after corticosteroids, all that ground glass has pretty much resolved. I mean, there's still some areas. And then there are some more reticulations and coarse pattern, which is the underlying maybe fibrosis that has already ensued. So if you compare this to UIP, they're kind of two ends of the spectrum in terms of looking. NSIP tends to be more soft, homogeneous, it's a little patchier, and again we have that characteristic subpleural sparing. But on the opposite end of the spectrum, we have IPF, UIP, which is coarse, it's a lot of irregular lines, reticulation, and there's honeycombing, right? And rather than the subpleural sparing, the disease comes all the way to the lung edge. And so here we can see some nice characteristic images. Again, ground glass admixed with reticulation, subpleural sparing in NSIP. Again, here we see reticulation, basilar predominance, subpleural involvement, and the characteristic honeycombing that we've come to expect with a UIP pattern. Now, just a note about chronic hypersensitivity pneumonitis. This is characterized by what we call very heterogeneous lung on CT. And so we've got areas of ground glass attenuation, reticulation, and then we have these areas of hyperlucent lung or black lung that look to be sort of groups or isolated secondary pulmonary lobules that are hyperexpanded. And ultimately, if you do expiratory imaging, these may, or you wouldn't be surprised if they trap a high degree of air. So this, at TLC, when you see the ground glass reticulation admixed with air trapping, this is what we call the head cheese sign. This can be segmental, the pattern can be segmental, there may be airway thickening because it is an airway process. You certainly will see reticulation. There may be a basilar predominance in about a third of cases. But the extreme lung bases may still be spared. And as you know, there may be some subacute findings depending on the chronic antigen exposure, and most of the time we don't know what antigen has caused this process. So here we see just a different case. Again, we can see quite a bit of ground glass associated with this, admixed with areas of fibrosis and what turns out to be lobular sparing or mosaic attenuation due to air trapping.
So our next case is a 45-year-old African-American male with a 3-month history of cough, dyspnea, and intermittent fevers. So what is the most likely diagnosis here? Is this subacute HP, stage 2 sarcoidosis, silicosis, or miliary TB? Please vote. Great. You guys are right on. This is indeed stage 2 sarcoidosis. What we saw here was a completely different pattern, a micronodular pattern of nodules less than 1 centimeter that are too numerous to count. Moreover, these nodules were really preferentially lining areas that involve the lymphatics, such as the pleura, the fissures, as well as the axial interstitium or the bronchovascular bundles. On the axial views, we saw that the distribution was slightly more preferential to the mid to upper lung zones. And if you paid some more attention to the nodes, you did indeed appreciate that there were, even though these were lung windows, some degree of mediastinal and hilar adenopathy. So this indeed was stage 2 sarcoid.
All right, so as you may have guessed, we're heading into a different gamut of nodules or a nodular pattern. Now, when differentiating nodular pattern of disease, it's really important to understand the structure of the secondary pulmonary lobule. And by that, here we have a unit, the secondary pulmonary lobule. It ranges in size anywhere from 1.5 to 2.5 centimeters. And you see that here's the pleura. You see interlobular septa. And within the interlobular septa, you have the septal vein. And each secondary pulmonary lobule is subtended by a lobular bronchiole and an arteriole, and that has a little bronchial artery, and also there are lymphatics that run all along this, as well as within the septa and along the pleura as well. And so here we see on CT just kind of what that secondary lobule, pulmonary lobule would look like. So when dealing with this nodular pattern, you're trying to figure out what the nodule's relationship to the secondary pulmonary lobule structures are. And that gives you maybe some insight as to what the distribution pattern overall is of where these nodules are caused by or where they're locating. And so what really you want to look at are the relationship of these nodules to the fissures, the pleura, the septa, and make the observation, are these nodules clustered or are they kind of just diffuse and random? And we'll go over this. So if you're dealing with a small subcentimeter nodular pattern or a lot of them, first question you want to ask yourself, are these nodules on these lymphatic pleural surfaces? Are they on the fissures? Are they on the pleura? Are they on the septa or on the peri-bronchovascular lymphatics? Next question you want to ask yourself, are these nodules clustered, or are they sort of isolated and you see one at a time? And when you decide on localization, these are the patterns of distribution. So you think of perilymphatic patterns of nodules, random patterns of nodules, centrolobular, meaning it's the center of the secondary pulmonary lobule, or is it more of a small airways pattern? So let's break this open a little bit. If we see most of these nodules congregating in areas that contain lymphatics and pleura, the fissures, the septa, and the pleura, as well as the peri-bronchovascular lymphatics, if we see that, we're really dealing with a lymphohematogenous process. This could be isolated to just a perilymphatic process, sarcoidosis, silicosis, lymphangenic carcinomatosis, or it may be that it's a random pattern, meaning that, for instance, Mets and miliary infection are seeding those lymphatic structures, but they're also going elsewhere within the lung. If we don't see this sort of lymphatic pattern, then we're really dealing with the kind of an inhalational process. So the agent is coming in through the airways. It could be more generalized in a centrolobular pattern, meaning it's hitting all sorts of airways at one time, as in the case of smoking-related lung disease, hypersensitivity pneumonitis, or it may just be isolated to the airways and kind of clustered and focal, and in cases of cellular bronchiolitis and pan-bronchiolitis. Now, if we add the clustering, meaning that these nodules are clustered on surfaces, if they are clustered and we are dealing with the perilymphatic process, you're really talking about sarcoidosis for the most part. And if you see them clustered but not in a perilymphatic way, and none of those surfaces are involved, you're really talking about a small airways process. So in addition to the distribution, localization, sometimes the morphology of the nodule is important. The density. How dense is it? Is it small, dense, or soft tissue as opposed to more ground glass? What are the edges like? Are they sharp, ill-defined? And what's the morphology? Are they branching or what we call tree and bud? So let's look at the perilymphatic pattern. And up here you see a diagram. Again, we see the secondary pulmonary lobule, the subtending lobular bronchus, and the artery. And first of all, you notice that these nodules are small and very dense with sharp margins. Next, you know that, look, they're involving all these lymphatic structures that we talked about, the septa, the pleura, the peri-bronchovascular lymphatics. Now, some would say that you need at least 10% of the nodules going on those surfaces to call it that these surfaces are involved. Others would say greater than 90. And again, you see that they're clustering to the lymphatics. And so really, again, this is characteristic of perilymphatic disease, sarcoidosis, silicosis, and to some degree lymphangenic cancer. So here, again, we see some cases, different case. We see, again, look at where all these sort of well-defined soft tissue nodules are. They're on the fissures, they're on the pleura, and they're on the septa and along the peri-bronchovascular lymphatics. Here you see the specimen of loosely formed granulomas and interstitial thickening, which is characteristic of sarcoidosis. Here we see in a different patient, again, you see nodules, but you see that the nodules are again on the septa, you see them on the pleural surfaces, the fissures, and along the peri-bronchovascular lymphatics. So this is a perilymphatic process. First and foremost, you think of sarcoidosis. Here we just have another image. Again, look at the fissures, just beaded with nodules, right? You see septal thickening and nodularity, pleura, and again, some beading of the peri-bronchovascular lymphatics. Now, here we see a case where you got larger irregular nodules, but that really shouldn't dissuade you from thinking that it may be sarcoidosis, because look at where these nodules are. Again, along the fissures, along the septa, right? and along the Peri-Bronchovascular or septal lymphatics. And so again, this is another case of sarcoidosis. Now, with sarcoidosis, sometimes you'll get architectural distortion, meaning that the lay of the land is not quite what it should be, and areas of lung look to be stretched, others sort of distorted and cicatrized, and that's because this is a chronic inflammatory process. You may see this, what we call peri-bronchovascular beating. And so when we look at the bronchus, the bronchioles and the bronchi, as well as the arteries, they look like they have little nodules or studding along the surface. As that fibrosis sets in with the chronic inflammation, you may see sort of this angulated bronchovasculature because of the distortion and fibrosis associated with it. If you were to look at this patient in maybe three, sort of divided them into thirds in a coronal situation or plane, you can see that characteristic of sarcoid, the apico-posterior segments are the first and most severely involved, and it's a middle third disease here. See that in two different cases. And as you all know, these areas of fibrosis are going to gravitate to the mid and upper lung. And again, coronal, sagittal reformats, as well as chest x-ray, really help you in cases of diffuse disease to see where the concentration or predominant portion of the disease is. And here, in some cases, you might see honeycombing even in cases of sarcoidosis. Rare presentations or features of sarcoidosis, you may see ground glass attenuation or even airspace attenuation, as is in this case of alveolar sarcoid. You might see septal thickening, as you can see here. Now, a lot of times, if you see a lot of septal thickening, rather than lung infiltration itself, you might want to think of a cardiac or cardiac involvement of the sarcoid with heart failure. And on some occasion, you can have what we call bullous sarcoidosis. And so this is due to air obstruction and cyst formation, as you can see in this case. And on rare occasions, you may see pleural effusions, but again, that may be in the context of more cardiac sarcoidosis with heart failure.
All right, moving on. 28-year-old male presenting with a 6-week history of fevers, night sweats, non-productive cough, and 25-pound weight loss.
I think every year we say that we want music,
Yeah.
but we forget to do it.
So what is the most likely diagnosis here? Subacute HP, stage 2 sarcoid again, silicosis, or miliary TB? Please vote. Great. The majority of you got this indeed right. This is miliary TB. If you just go back, Rob, we did see nodules that were too numerous to count. They were clearly involving areas lined by lymphatics. We clearly saw fissures were involved. The pleura was involved. But there were also nodules that were not involving those areas, nodules that were kind of randomly dispersed without predilection to the perilymphatic structures. And that's what we call random. And certainly in this case, it would be a hematogenous infection that would work. Hematogenous Mets would be a possibility here. Certainly, usually there would be variation in the sizes, as Rob will point out. Occasionally, papillary thyroid cancer can give you very, very small millet seed nodules, not dissimilar, but often there, too, there is some variability and not necessarily these millet seed nodules, as we see here with hematogenous spread of tuberculosis.
All right, so now we're kind of talking about random nodules and moving away from perilymphatic. And so here again, you can see nodules fairly well defined, well marginated, and carry a little bit of soft tissue density, or at least more than just simple ground glass. Now, again, when you ask this question, are they involving the lymphatic surfaces? Yeah, you have a few on the pleura, you might have a few on the septa, you might have a few along the peri-bronchovascular lymphatics. But then you have other nodules that, hey, I don't know, they're just kind of floating in space within that secondary pulmonary lobule. And so when you see this sort of kind of distribution involving the perilymphatic surface a bit more, and you can't place some of these nodules, this is what we describe as a random pattern. When you're dealing with random pattern, really you're only dealing with sort of this lymphohematogenous spread of malignancy or infection. So again, clustering, not so much clustering like we saw with the perilymphatic diseases with all the nodules on the lymphatic surfaces or structures. So this is what random looks like. You can certainly see nodules on the pleura. You can even see some nodules lined up along a septa, but other nodules are just kind of thrown out there, and what you have is a fairly homogeneous perfusion. Like if you move your eyes from the lateral part of the lung to the medial part, you kind of see an evenness to this distribution of nodules. So with random distribution, they're fairly uniform. They're not clustered. They may be lower lobe predominant because if they came in via the bloodstream, it's going to go where the blood flow is the most. They're solid density with sharply defined margins. Now, some of these nodules may share similar size depending on the gradient. So, for instance, if they're all getting to the lower lung by blood flow, sometimes the earliest metastases may be all very similar in size and larger down in the lower lung than in the upper lung. There may be a feeding vessel sign owing to the fact that they're vascular borne. They may cavitate, and if it's, they may involve lymphatics as they sort of take up residence in that area. So when you're dealing with metastases, we're dealing with renal, testicular, thyroid, and melanoma. With miliary infections, we're talking about tuberculosis, but other fungal infections like cocci, histo, and even pneumocystis, and sometimes occasionally viral infections. Again, you see that, again, the lymphatic surfaces are certainly involved, but you see a lot of other nodules that seem to just be floating within the lung parenchyma itself. And here, again, in another case, we see some effusions. But look at all these nodules. I mean, like when you look from the medial lung to the lateral lung or top to bottom, it looks all fairly homogeneous. But the nodules are all over, fairly equal throughout the lung. Now, just a few words about lymphangenic cancer. Again, this is a perilymphatic process. It's characterized by smooth or regular or sometimes even nodular septal thickening. And it's a much more linear disease or a reticular disease than a nodular disease per se. There may be some, frequently there's axial involvement. Generally, there's no architectural distortion because cancer in itself doesn't necessarily scar unless it's been treated. There may be adenopathy in about 30% of cases, maybe pleural effusion. And the entities that we're talking about are the adenocarcinomas, the unknown primary, but certainly lung, breast, colon, and pancreas. And again, compare and contrast what we saw with the other, for instance, the perilymphatic sarcoid. Here it's a much more septal disease. It's more linear. Yes, we see some nodules, but that's really not too much of the feature. And for the most part, you see preservation of the architecture, and the secondary pulmonary lobules are not very distorted. And here we just see another case of lymphangenic cancer. Again, a lot more lines or septal thickening. There are a few nodules here and there, but again, it's a more linear disease. And on the soft tissue windows, you can see the mediastinal and bilateral hilar adenopathy in this case.
So our next case is a 23-year-old female non-smoker with a 3-month history of increasing dyspnea and dry cough. I think that these are a little bit harder to see. That's why we have it magnified here, just to get a better sense of things. So what is the most likely diagnosis here? Is this RB-ILD? Is this subacute HP? Is this pneumocystis jirovecii pneumonia? Or is this pulmonary coccidiomycosis? Please vote. Great. It looks like the top two choices are the ones that are most correct. What we see here are, again, nodules that are too numerous to count. And nodules, if you look carefully, they did not have a perilymphatic distribution. They were actually not involving areas lined by lymphatics. They were not involving the fissures, the pleura. And the morphology of these nodules is very poorly defined or ground glass, and they're rather diffuse. There is no clustering, it's rather diffuse. So this takes us into that inhalational category and that more diffuse involvement that we call a pure centrolobular pattern. And of the two choices, the reason why subacute hypersensitivity pneumonitis, first and foremost, is probably more correct here, is because in that little brief one-liner we did say a non-smoker, certainly RBILD, that occasionally tends to be a little bit more patchy, would be expected in a smoker, whereas subacute HP would be in a non-smoker, as in this case.
Okay, so here we have the secondary pulmonary lobule, and when we call centrolobular, we're talking about something within the center of that secondary pulmonary lobule. And the core, often these things gravitate or surround the core structure, which again consists of a arterial, a bronchial, lymphatics, and a bronchial artery. Now sometimes you'll see, if you know what the cause or how the nodule or the pattern got there, if we really think it's an airway process, we may use the term rather than centrolobular, but call it bronchocentric or bronchiolocentric. If we think that it's more hematogenous, as in the case of maybe METs, then we will call it angiocentric and so forth. So centrolobular nodules can be solid, but more often they're going to be this sort of ground glass. Generally they're going to be bigger, maybe 5 millimeters or larger, fluffier looking. They may be branching, and they may be tree and bud, which are these sort of kind of jacks, or they look like jacks. And again, if you impose or superimpose the secondary lobular structures, you see all these nodules are in the center or clustered to the center of that secondary pulmonary lobule. So let's look at this on the diagram that we've been looking at. And here we see, again, a fluffier, less dense nodule, generally bigger in size, less density, ill-marginated or fluffy, right? You see that none of the perilymphatic structures that we've been talking about are involved by these nodules. The fissures are spared, the septa are spared, the peri-bronchovascular structures are spared. So there is no perilymphatic or lymphatic structure involvement. There's no clustering, fairly homogeneous within the secondary pulmonary lobule and, for that matter, within the lung itself. So there's no clustering, no lymphatic structure involvement. Brings us into this centrolobular pattern or inhalational pattern, more diffuse things like cigarette smoke causing RBLD or antigen exposure to organic agents, most commonly in the form of subacute hypersensitivity pneumonitis. HP can be acute, subacute, chronic, depending on the length of time and exposure. Acute tends to be more ground glass attenuation or even airspace attenuation. As the granulomas form, you might start seeing centrolobular poorly defined nodules. Subacute is much more of the nodular pattern that we see. There may be also air trapping at this point, as you can see here, which are these areas of parenchymal lucency or blacker lung. And then certainly in the chronic phases I've already shown you, you're going to see the fibrosis. Here again we see a more involved case of subacute hypersensitivity pneumonitis. Look at these nodules. They're ground glass. They're bigger. They're in the center of the lobule such that you almost see kind of a separation from clusters of nodules because that's the outer part of each of those lobules, right? And with regards to respiratory bronchiolitis, interstitial lung disease, again, this also has a very similar, if not almost identical, centrolobular pattern favoring the upper lobes. There may be also some airway thickening. This is seen exclusively in smokers. And basically, it's a smoker with a symptomatic, who becomes symptomatic with shortness of breath and cough, maybe a mixture of PFTs. And this is what this disease is basically an overproliferation and infiltration of the parenchyma and around the airways with this pigmented macrophages, or the alveolar macrophage. Some people feel, or most people feel, that this is on a spectrum of disease, our respiratory bronchiolitis being the least sort of severe, going all the way to DIP. Here we see again, you can see that there's just a diffuse ground glass pattern. None of the lymphatic surfaces are involved. There's no clustering. And so this is an inhalational process. The two things that should come to mind are subacute hypersensitivity pneumonitis and RBILD.
So case 6 is a 63-year-old Japanese female with a 3-month history of chronic cough, weight loss, and subjective fevers. So what is the most likely diagnosis here based on the brief clinical history and the radiographic features? Is this Mycobacterium avium intercellulare or complex? Is it pulmonary TB with associated endobronchial involvement, metastatic bronchogenic cancer, or pulmonary coccidiomycosis? We have to always bring that up. We're in California. Please vote. Okay, there is a little bit of a spread here, and let's just quickly go over this. What we saw here were a number of features. There were macronodules that were cavitating, and they were thick-walled cavities there. And then there were also adjacent micronodules that had a patchy distribution that were clearly centrolobular. They were not involving areas lined by lymphatics, and they had a Y-shaped or tree and bud morphology. That constellation here really makes TB with endobronchial spread more likely. Now, the endobronchial or cellular infiltrates can be a feature of MAC, but with MAC you'd often expect more localized disease, more bronchiectasis. The macronodules here is really what points to this perhaps being TB with endobronchial involvement causing those micronodules that are tree and bud and patchy in distribution.
Okay, so we're kind of moving on to small airways disease, and the small airways are those without cartilage, and these are generally 2 millimeters or less, and they represent bronchioles, or in some cases very small bronchi. And so the bronchioles that we're talking about are the membranous, terminal, and respiratory bronchioles, and this has sort of changed over the years with better CTs, and we can probably resolve these bronchioles even maybe 1 centimeter from the pleural edge. So the direct signs of small airway disease are going to be the things that involve the small airways. And so, again, we talked about ground glass nodules. We see branching nodules. We see what we call tree and bud, or the sort of jack sort of shaped nodules. And we may, as the process becomes more chronic, we may even see bronchiolectasis, or dilation of those very peripheral small airways. And so these are all forms of sort of direct signs of airway involvement. Now, if we go back to our diagram, we see that, again, unlike the centrolobular pattern of nodules, we see that, again, these nodules still are going to be air-spaced or maybe ground glass, or maybe, but maybe overall carry slightly more density. They are clustered, but not necessarily on a lymphatic surface, but within the secondary lobule itself. And so here again, we don't have any perilymphatic or lymphatic structure involvement. They're clustered, not very dissimilar to the more ground glass centrolobular pattern that I showed you just before this. So when we see this clustered pattern, centrolobular nodules, we're really focusing on the small airways process. And this is generally going to be a cellular bronchiolitis, of which most commonly is going to be an infection, or pan-bronchiolitis. So here again we see, again, notice that we see the clustered nodules here isolated to the center of the secondary pulmonary lobule. You don't see any sort of nodules on the lymphatic surfaces or structures, and you see that it's kind of patchy. It's not all the way throughout the lung. It's sort of isolated to this area, that area, other areas. And what's maybe helpful if you see it is that maybe the airways that are subtending that area are maybe thickened as well, indicating or indicative of an airway process. Here we see just a little bit more involvement. We see, again, these sort of little denser nodules. Some are kind of ground glass, little fluffy. Some have a tree and bud look to it. We see that, again, the lung is not homogeneously sort of involved with these nodules, and none of the lymphatic structures are. We also see more centrally that the airways are quite thick. Again, suggestive that this may be an airway process, which indeed it is. And we also see a little hyperinflation, which may indicate air trapping. So pan-bronchiolitis is seen in Asians, mostly Japanese. It's a diffuse pattern or cellular bronchiolitis. They can get colonized with Pseudomonas, and it's accompanied by pansitis. With HRCT, we see small centrolobular nodules in a tree and bud fashion often. And again, as the disease progresses, we see more large airway involvement. In the later phases, we may see cysts, bullae, and air trapping. Here we see 2 cases of pan-bronchiolitis. Again, you see, first and foremost, you see dilated airways with thickening, and then you see small clustered nodules, tree and bud, again, within the lung or in the center or central portions of the secondary pulmonary lobules, but none on the lymphatic surfaces. And again, it's a patchy disease, not like an inhalational process where it's much more homogeneous. So there are some indirect signs of small airways disease, and you may come across the term mosaic attenuation. And mosaic attenuation is when you see hyperlucent and hypolucent lung or gray lung sort of juxtaposed to against one another, and they're in a geometric fashion corresponding to either isolated or clusters of secondary pulmonary lobules. So here we see gray lung and black lung simply, and again, it's a very geographic pattern, and you can kind of imagine that these areas correspond to clusters of those secondary pulmonary lobules. Now, when we see this pattern on inspiratory CT, we ascribe the term mosaic attenuation. Now, the other thing that you want to take note is that the dark areas often are devoid of vasculature or small, or they're attenuated or smaller in caliber, and that's because these areas are generally going to be perhaps air trapping or obliterated, and they're shunting blood to the more gray areas of lung. Now, on expiration, when this pattern becomes much more pronounced, meaning that the gray and the black lung become much more obvious, and you can see a more obvious gradient, on expiration, that's what we call air trapping, okay? So if you see mosaic attenuation, these are the 3 things that you think of. It's an obliterative small airways process, obliterative vascular process, or maybe you just have an infiltrative process in the lung that fortuitously is giving you this pattern, okay? And I'll show you, again, you want to analyze it a little further, and if those areas of very black lung have very small or sparse vessels, then you can kind of take this process out for the most part, and really it comes down to one of these 2 things. And the way that you differentiate between obstructive small airways versus an obliterative vascular process is, you guessed it, to do the expiratory imaging. So what does normal expiration look like? And here we have a patient on inspiration and expiration, and so as the patient expires, the lung becomes grayer. And it becomes grayer with a dependent gradient, meaning that as you go to the more dependent area, it becomes grayer because of blood flow. And you may have small areas of air trapping, but notice that, again, it's not really very profound, certainly not any more than about 25% of a lobe or even on that one cut, and certainly not a lot of air trapping in the non-dependent lung. So on top you have a normal inspiration and expiration, and down below you have inspiration and expiration in a different patient. Now, first of all, you notice on the image on the lower left, you can see that, wow, there's this crazy mosaic attenuation, right? Now, when we look at the gray lung and the black lung and compare, notice that the black part of the lung has almost no vasculature, right? When you see this, this is really called mosaic hypoperfusion, and what you're thinking here is not of an infiltrative process, but first and foremost, obliterative small airways disease or a obliterative vascular process. Now notice on the expiration, right, it almost looks the same, if not the black areas look even more pronounced. The gradient between the black and the gray lung is preserved and even accentuated. And so in this case, this is due to air trapping. Now, here's another case. Here we've got on top, we see again, mosaic lung attenuation on inspiration. But notice how the black lung almost has no vasculature, or what the vessels that we see are very attenuated. And so we're really focusing on these two processes. When you do the expiration, that gradient becomes really pronounced. So rather than thinking of vascular causes, you steer yourself to a small airways or air trapping process. Now look at this case. Here we have a patient with large sort of central thromboemboli. And you can see that, again, there's mosaic oligemia or mosaic attenuation with gray and black lung. The dark lung, the vessels are again attenuated and smaller. But now let's do the expiration. So on top we have the patient with thromboembolic disease. We have the inspiration and expiration. And notice that these black areas become grayer, right? Because they're not holding on to air or not air trapping. And so the hypoperfused lung, because the clot won't let blood perfuse that lung, becomes grayer and can expel air and becomes grayer. And the more hyperperfused lung also becomes grayer. And so that difference between those two areas, or that gradient, does not become more accentuated, okay? Unlike the case we have below. So let's think about it in a sort of cartoon sense. So we'll take the case of air trapping. So here we've got, again, black lung, gray lung, right? So this is on inspiration, and then what do? We have them expire. What happens? Well, the areas that trap air stay black or become blacker, and the areas that are gray, because they're not trapping air and can force the air out, become grayer, so that gradient between the two becomes accentuated. Now let's look at this case of no air trapping as in the case of chronic, in the PE case. So again, we have a little bit of a gradient to begin with, because we've got black lung because it can't get perfused because the PE is in the way or the emboli are in the way. We have gray lung that is hyperperfused or shunted too. Now on expiration, well, there's no obstruction here from the airways, so both can expire air. The hyperperfused area becomes grayer. The underperfused area becomes grayer too. The gradient really doesn't become accentuated. All right.
All right. Case 7 is a 29-year-old African-American male with a 2-year history of progressive dyspnea and cough. Moving on to a different pattern here. Okay. What is the most likely diagnosis? Is this lymphangioliomyomatosis, or LAM, or is this pneumocystis jirovecii, Langerhans cell histiocytosis or granulomatosis, or lymphocytic interstitial pneumonitis? Please vote. All right, so slight majority got this right. I think the key here, this is a cystic lung disease. They're clear, defined cysts. They're walls that are appreciable. Moreover, the intervening lung that separates these cysts was not normal. The unaffected lung actually had slight nodularity and irregularity, and that's really one thing that, as Rob will talk about, will help distinguish a disease like Langerhans cell histiocytosis, where the intervening lung is often nodular because the disease often starts off with nodules that cavitate and then form cysts, versus LAM, where the intervening lung is almost pristine. So really, if you think about those two as being the primary processes in a differential here, you can clearly see that the unaffected lung here, I mean, this is a very advanced case. This patient actually ended up going for heart-lung transplantation because he actually had group 5 pulmonary hypertension from the Langerhans. But nonetheless, the intervening lung was very abnormal here. There was really no normal lung.
Okay, so now we've moved on to the category of cysts, and as Nader mentioned, the two foremost diseases are Langerhans cell lymphangiomyomatosis, but there are other cystic diseases that we'll talk about. So cysts are round parenchymal molucencies, usually thin wall, typically containing air, but sometimes they can contain fluid or even soft tissue. Cavities develop within sort of nodules or areas of consolidation. So when you're dealing with predominantly a cystic pattern, then again, there are some questions you like to sort of ask yourself. First of all, is there a perceptible wall to these cysts? Yes or no? And what is the relationship of this cyst to the centrolobular core structure that we talked about? Does it look like the core structures or like the arterial, the bronchial are going through the center of the cyst? Or does it look like they're sort of embedded and sort of plastered against the wall of the cyst? As Nader mentioned, you also want to see or look for nodules, yes or no? And is there an upper, lower lung predominance of these cysts, if anything? So these are kind of the questions that you like to ask. And when you're dealing with cystic lung disease, these are probably the most probably the first four most common. Centrolobular emphysema by far, Langerhans cell lymphangiomyomatosis, lymphocytic interstitial pneumonia, and the Burt-Hogg-Dubé. I know we kind of always talk about it, but we don't see it that often. So let's look at the case of centrolobular emphysema. So first of all, here we see kind of in a mid cut here, we see these little holes in the lung throughout. And the first question you ask yourself is there a perceptible wall? I think you can pretty much see that although you see the cysts, you don't really see a wall around them. That's very obvious. And when you ask your next question, what's the relationship with the core? And again, you look at some of these, and it looks like the centrolobular core structures are going right through the center. And I have some better images of this, but look at this. Looks like that structure is going right through the middle of the cyst, and that's because these cysts are clustering around it. There's obviously no nodules, and it's favoring the upper lung. We're talking about centrolobular emphysema. So this is what I meant about this core structure going right through what it looks to be going through the center of that cyst. And again, that's because the lung destruction is occurring all around the core structure, affecting the respiratory bronchioles in the center of the secondary pulmonary lobule. So let's look at, for instance, compare and contrast with LAM. Okay, so here again we see cysts, right? Dark little air-containing foci. But the difference when you compare that to emphysema is that all of these cysts have a little bit of a wall, right? 1 to 2 millimeters. And if you look closely, the core structure looks like most of these cysts don't have anything seeming like they're running through the middle of it. And if you look at the core structures, they look like they're embedded or plastered within the wall itself. Certainly no nodules, and again, and I don't show you all the images, but I guarantee that this is a more diffuse process. This is lymphangiomyomatosis. So as you know, this occurs in women of childbearing age. In 30% of these cases, you can have renal angiomyolipomas. And what this represents is an abnormal proliferation of smooth muscle affecting the peri-bronchovascular structures. If it's affecting the airway, it causes obstruction and cyst formation. If it's affecting the lymphatics, you get chylous pleural effusions in almost in as much as 3/4 of those patients. Again, here you can see the gross specimen that kind of goes along with the CT. you can see that the cysts are going to be numerous, they're thin-walled, and in between those cysts, unlike Langerhans cell, you have fairly normal intervening lung. You may see nodules, but that's so exceedingly rare that you almost never see that. And because it's a cystic lung disease, in 30 to 40% of these cases, the presenting sign may be a pneumothorax. And here we see just a number of different patients with LAM of varying severity. And you can see that, again, look at that. The cyst and the core structure looks like it's embedded in the wall. You don't see any of these cysts have something going through the center of them, and they all have a thin perceptible wall, normal intervening lung, no really zonal predilection for these cysts, but fairly diffuse. And these are cases of LAM. So tuberous sclerosis can also give you cystic pulmonary disease that's identical to LAM, with the exception of the chylous pleural effusions. The triad, as you all know, associations or other sort of ectodermal issues, angiomyolipomas, cardiac rhabdomyomas, retinal phacomas, osteomas, and subungual fibromas. And again, when you look at the lung disease pattern, it looks identical to LAM. All right, so moving on to the next entity, we're going to talk about a little bit about Langerhans cell. And again, you ask your question, you see the cysts, so you ask your question, do I see walls on these cysts? And I think everybody can certainly see walls on these cysts, right? And then you look at the core structure and the relationship to the cysts. And again, you don't see anything really going through the heart of the cyst or the center of the cyst, right? It looks like the core structures are all, again, plastered or embedded in the wall of the cyst. And here, I don't show you too many nodules, but this entity certainly has a much more predominance of nodules than certainly LAM. So this goes through stages, starts with a bronchocentric or centrolobular nodule. That nodule grows and cavitates, then becoming what we call these thin-walled bizarre cysts. These cysts may coalesce, and you get areas of pseudoemphysema and fibrobullous disorganization and destruction and intervening fibrosis. In the early stages of disease, you won't have fibrosis, but later on there is. There generally is a sparing of the extreme lung bases as well as the tips of the right middle lobe and lingula. And again, here we can see just how many nodules. These are all small little nodules, and you can start seeing down on below some of these nodules starting to cavitate and become cysts. And as the disease progresses, you can see, again, more fibrobullous changes, more extensive cysts. Look at the intervening lung is just highly abnormal, and then you get sort of this fibrobullous disorganization in the most severe cases. Okay, moving on to cystic LIP. You see, again, cysts, maybe not so numerous, with a perceptible wall. With regards to the association with the core structure, you may see some cysts with things going through the center, as I'll show you, or embedded in the wall. There may or may not be any nodules, and localization is usually just kind of scattered cysts as opposed to the more diffuse proliferation of cysts as we've seen. So at least Jacot looked at the radiographic features of LIP, found that ground glass attenuation was the most common and that was tied with centrolobular nodules in almost all of their cases. They sometimes see perilymphatic nodules in a high number of cases because this is kind of a lymphocytic or lymphocyte process. And that's what you see, these small little ground glass centrolobular nodules. And here again, you see more lymphatic-based nodules in another case, and maybe some septal thickening, indicating a lymphatic or lymphatic process. And here we see the kind of cysts that we're talking about in about almost 70% of cases. Again, you see a wall that's perceptible. And in some of these cases, you can see that kind of the structures are against the wall. And here, you can see the core structure kind of in the center with a number of cysts sort of clustering around it. And so with LIP cysts, or the cystic variant, these cysts generally tend to be 3 centimeters or less. Sometimes they're this multiloculated or lobulated or multiseptated cysts. And generally you can count them They're not so many and numerous as in the other cases of cystic lung disease that I've showed you. And collectively, they may only have 10% or less lung involvement of these cysts.
Case 8 is a 53-year-old female with a 1-month history of persistent non-productive cough, dyspnea with exertion, and some weight loss. So what is the most likely diagnosis here? Is this MAI, acute interstitial pneumonia, metastatic bronchogenic carcinoma, or organizing pneumonia? Please vote. Great. So we've moved on here to the last category, which is airspace disease. And as we see here, we saw airspace disease that was mostly bronchocentric as well as peripheral. We had areas of patchy airspace disease along with bronchial wall thickening. There was also some areas that you could vaguely say there was maybe a reverse halo sign or atoll sign that was, it's only found in about 20% or so of patients with organizing pneumonia. But clearly, this is an airspace disease, and as Rob will talk about here, clinical history is really important when you're dealing with airspace disease because the differential is often very broad.
Okay, so again, these are some of the other entities that we see that's predominantly characterized by airspace disease, acute and chronic eosinophilic pneumonia, acute interstitial pneumonia, and diffuse alveolar damage, and pulmonary alveolar proteinosis. So with organizing pneumonia, the pathology is patchy organizing pneumonia with intraluminal fibrosis involving the bronchioles and air spaces. And there's often these sort of endoluminal granulation tissue polyps or mesome bodies. And there may be some interstitial infiltrates or inflammation associated with this as well. This sort of honeycombing architectural distortion associated with fibrosis is not very common with organizing pneumonia. The CT features are predominantly consolidation with a lower lung predominance. Sometimes there may be ground glass opacities. And the distribution, again, within the lobe itself is going to be subpleural and sort of peri-bronchovascular. So it's a combination. Other less common features, you might see bronchial dilation. You may see a non-septal linear or reticular pattern. There may be more obvious nodules and masses in 15% of cases. And overall, as you know, fibrosis is fairly uncommon, and certainly honeycombing is not a feature of this disease. So here we see some of the common things. Here we see a consolidation, airspace attenuation. We see that after treatment, there's a little residual ground glass that ultimately probably will resolve. And here we see more extensive ground glass in a different patient. We see the bronchial dilation in the areas of heavy involvement and even a little peribronchial thickening, which is not unusual. In this bottom case, we see more reticular pattern. Yes, there's ground glass, but you see a lot of lines here, and this is what we call kind of the non-septal reticular opacities. In this pattern here, you can see that the ground glass or the sort of thickening is confined to the edges of the secondary pulmonary lobule. And this is what we refer to as a perilobular pattern. And this is seen, at least in one article, 57% of the cases of organizing pneumonia here. And again, if you think back to that diagram I showed you with all the secondary pulmonary lobules, you can see almost make them all out here. The only difference of the septa being, rather than the septa being thick, it's more kind of consolidation outlining the edges there. There may be, as I said, more obvious nodules and sort of mass-like consolidations in 15% of patients. Again, it's a subpleural peri-bronchovascular kind of combination. And rarely and uncommonly, you may get to this point where there is actually fibrosis caused by this, this entity. This is what Nader was referring to as the reverse halo sign that you see in almost 20% of patients. So what you have is basically an area of dense consolidation, and within the center of that consolidation, you see ground glass attenuation. And so this is supposedly like an atoll, which is an isle in the ocean, right? And here, just a different case of radiation-induced organizing pneumonia. Again, you see that very dense leading edge, and within the inside of that leading edge, you see ground glass attenuation. Moving on to a little DIP. Again, this is characterized by ground glass opacity that you see here. It often favors the lower lobe, subpleural lung, can be patchy or diffuse, as I've shown you. In 10% of cases, you may see small little cysts here, and that's due to airflow obstruction. And they also may just represent fortuitous or intercurrent emphysema as well. And again, with this entity, you really don't see too often honeycombing. Now, with any airspace disease, you want to try to differentiate the sort of the features and tease them out. Again, looking at the distribution, whether or not there's architectural distortion accompanying lymphadenopathy. If you have it, is this an acute or chronic process, whether it's clinically or radiographically? Has there been a history of treatment response? What's the patient's occupation, immune status? Are they on any new medications or drugs that are associated with lung disease? And ultimately, you may just have to get biopsy results. Here are just some other airspace entities. Here we see a peripheral lung involvement favoring the upper lobes. This is a chronic eosinophilic pneumonia. Here we see, again, more of a kind of ground glass in the right lung, more dense airspace consolidation in the other lung. And this is a case of the mnemonic form of bronchoalveolar cell carcinoma. Here we see these cases are what we call crazy paving, and you may run into this term. And what we mean by crazy paving is that you see ground glass attenuation, and within that area of ground glass, you see this linear pattern of interlobular septal thickening, as well as intralobular septal thickening, resembling sort of pave. Okay, so here again, you see that everywhere you see ground glass, you see the inter and intralobular septa being thick. Crazy paving has been associated with primary alveolar proteinosis, but can be seen in a number of things, and it certainly is not pathognomonic for just PAP, but certainly you can see it in pneumocystis infection, mucinous BAC or adenocarcinoma in situ, that's the mnemonic form, even hydrostatic pulmonary edema, pulmonary hemorrhage, and Lymphoid pneumonia. So these are kind of the categories that we talked about: reticulations, nodules, cysts, and airspace disease, some of the common entities. Again, when you're dealing with a nodular pattern, and you're dealing with multiple or numerous subcentimeter nodules, first question you want to ask yourself is, are they involving the lymphatic structures? If that's the case, then you're really dealing with a lymphohematogenous process, whether it's perilymphatic or random. If not, you may be dealing with a more inhalational process. Then the next question you want to ask yourself is there any clustering of these nodules? If they are involving lymphatic structures and clustering, you're really talking about perilymphatic processes, primarily sarcoidosis. And if you're dealing with a more inhalational category, then you're dealing with small airways disease. And remember the morphology of the nodules as well. So here, I just put side by side all of the nodular diseases. So again, these are the patterns across the top, the pleural or lymphatic structures, perilymphatic random, yes, they involve those. Centrolobular small airways, no. The clustering, as we talked about before, perilymphatic and small airways, not so with the random and centrolobular. And the morphology of the nodules, perilymphatic, solid sharp, random, solid sharp, centrolobular. As we get to more inhalational or airway processes, these nodules become more ill-defined, right? Or even branching in tree and bud. The cystic lung diseases that we talked about, emphysema, LAMS, LCH, and LIP, again, you want to ask yourself, is there a perceptible wall? And again, emphysema, no, but the other three entities, yes, as you've seen. What's the relationship with the centrolobular core? Is if it looks like it's going right through the center of some of these cysts, that means that the cysts are surrounding that core fairly evenly, and that's what you see with centrolobular emphysema. If it's eccentric, you're probably dealing with one of these two entities, and if you have kind of both and these nodules or these cysts are much more finite, you may be dealing with, as is shown here, LIP. Presence of nodules, again, the only two diseases that have nodules, as I've shown you, are LCH and LIP. And localization, emphysema, as you know, is in the upper lung, LAM sort of diffuse with no zonal predilection, LCH sparing the bases, right middle lobe and lingula tips, and LIP, usually, again, a finite number of cysts, representing less than 10% of lung involvement, and they're kind of randomly scattered. Aerospace disease, again, I think history is first and foremost most important. And so that brings us to kind of, we'll ride out with a bunch of quiz questions.
All right, so just no history here. You guys are experts. What is the most likely diagnosis here? Is this UIP, NSIP, metastatic CA, or organizing pneumonia? Outstanding. Clearly, most everyone got it right. The degree of honeycombing that's present here, you would not expect to see honeycomb changes with NSIP. The disease would actually have a rim of subpleural sparing that we don't see here. The disease here goes all the way out to the pleural surfaces. It's very reticular, very coarse, very minimal ground glass. So UIP, as most of you got, is the right answer.
All right, the next case. Go ahead and vote.
Great. So here we had back to a micronodular pattern. Too numerous nodules, too numerous to count. Clearly, the nodules look like they are involving the perilymphatic structures. Moreover, they are clustering along those areas, as Rob talked about. So if you look along the fissures, the pleural surfaces, and the axial interstitium, it looks like it's being riddled by micronodules. So it is a very perilymphatic disease. Moreover, these nodules are clustering in areas lined by lymphatics. So the best answer here would be sarcoidosis.
All right, next case. So on your left is inspiration, on your right, expiration. Same patient.
Fantastic. So there is quite a bit of ground glass, but as Rob talked about earlier, there is this mosaic attenuation that gets exemplified during expiratory scans. So you have these areas of lobular air trapping that is really pathognomonic of with hypersensitivity pneumonitis, in this case, case of subacute HP.
So let me just give you, so these are, the image on your far left is one patient, and the image in the middle and the magnified image are from the same patient, but a different patient. Please vote.
Go
ahead and vote.
Please vote.
Oh. Yeah.
There you go. All right, a little bit of work to do here. So what we're seeing here are cysts. They're lucencies, but without clearly defined walls. If you really try to draw an outline around these lucencies, it's very difficult. You don't see that thin 1 to 2 millimeter wall. Moreover, if you look carefully in some of the magnified views, you see that the central lobular core, the cyst surrounds that central lobular core, and that is pathognomonic for smoking-related central lobular emphysema. Langerhans cell histiocytosis or granulomatosis, you would actually have a perceptible wall, and the central lobular core is eccentric or pushed against the wall, and that is not the case here. So this is central lobular emphysema. How about this?
Go ahead and vote.
All right, so a majority got this right. This is clearly Langerhans. What you're seeing here are clearly defined cysts with perceptible walls. We're seeing two axial cuts, mostly mid and upper lung zones. And what we see is that the intervening lung is slightly abnormal. There are some slight nodularity to the intervening lung outside of the cyst. Moreover, the central lobular core structures look like they're eccentric or pushed up against the wall here. So this would be most consistent with Langerhans cell histiocytosis.
All right, the next case, please go ahead and vote. All from the same patient.
All right, great. 2/3 got this right. What we're seeing here are somewhat ill-defined nodular opacities that do not have a predilection for the perilymphatic structures. Moreover, they're clustering, and in some areas they do, especially on the sagittal and coronal views, have a tree and bud morphology. This is consistent with a cellular bronchiolitis and infectious bronchiolitis, and clearly the differential is pretty broad, would include things such as aspiration, Mycobacterium avium infection, TB with endobronchial spread, particularly if you have a foci like a large cavity, as well as atypical fungal infections such as cocci. So this is an infectious bronchiolitis. How about this case?
Think about the wall of the cyst.
Great. So here, in some ways, this is not too dissimilar from that central lobular emphysema Rob pointed out, with two distinctions. Number one, there is a perceptible wall. You can actually draw a nice outline, whereas with the central lobular emphysema, it was just kind of poorly defined lucencies. Secondly, the central lobular core here, unlike central lobular emphysema, is not in the center. The cyst is not surrounded, but rather it's eccentric or pushed up against the wall. And then what kind of differentiates this from Langerhans is the intervening lung here is pretty pristine. There is no involvement or abnormality of the intervening lung not involved with cysts.
And then the last case is this. So go ahead and vote.
Great way to end the day.
Right.
There
Wow.
you go, 97%. So this is clearly organizing pneumonia. You see areas, airspace opacities that are somewhat patchy, involving the peri-bronchial vasculature as well as periphery with associated bronchial wall thickening.
All right. Thank you very much. Give yourselves a hand. I think you're the highest correct answer percentage of all the audiences Nader and I have the privilege to teach. Have a good evening.